Actually, let me know if it doesn't progress.
Okay.
So yes. So gonna go over just broadly some wound care stuff. And it doesn't get into great detail, but it should give you kind of a good background just to kind of start from. And it's maybe new information for some of you, maybe repeat. It's not meant to you know let anybody know that you don't know it already and that kind of stuff. But there's some basic stuff in here, and it's really kind of just the nuts and bolts of how we look at a patient, assess their wound, how we measure it, and then I'll go over how we do the shorthand notes, which is critical. That's just kind of where you get your whole skeleton of how you're going to write your eventual note. And then the next section is really kind of more on the more typical dressings that we use. So we'll start out with going over the anatomical locations, how we do the measurements, different wound etiologies, the tissue types that the wounds have that you guys will see, drainage, odor, edges, and then wound pain and infection briefly. And then we'll go from there. So basically, the whole wound assessment is your guys' initial assessment of this patient. It really is supposed to be head to toe. A lot of the times they're going to have it be a little bit more focused, but always kind of keep your eyes open. Um, if you're rolling a patient over to see the sacrococcyx, take a look down at the heels, make sure there's no ulcers there. If you're looking at the heels on the left foot, also take a look at the right foot, things like that to kind of give you a good idea of what everything that's going on with this patient. And it's not just wounds that we're looking for, skin. See if they've got a trach, see if they've got a feeding tube, see if they've got a Foley catheter, see if they're on a low air loss mattress, see if they have any of those offloading devices that Bianca mentioned. All of that kind of has to kind of happen at one time. And as you'll get on your shorthand note, there really is a place for all of those things, for offloading, for different wounds, etc. And then etiologies, tissue types, all of that will be on your shorthand note. So it really is good just to get a good look at the whole patient. I've definitely been burned before when they've asked me to look just at one area and I didn't look at the other, and my document said, right lower extremity is fine. Do you guys have questions, Diana, or those are just from raising your hands from before? Where I've looked down at I'm looking at the left lower extremity, and I did not look at the right, but I documented, the right side was normal, and there actually was a wound on the right side, and it actually had been there. So always kind of take a quick look, especially that first time around. It's a skill that really does kind of take a little bit of time to learn. And as you're shadowing Diana, really kind of pay attention to everything that they're doing. It's going to go quick. So ideally, when you start, take your time, do it slowly. And then as you get more proficient at it, it starts to become something where I can just look at a patient and it's almost like a snapshot. And you can kind of see everything that's going on at once. And then each different skin location, when the patient's turned this way or another, I can get a good idea of what's going on. There's nothing worse documenting that someone's got a normal airway and are breathing fine when they've got a trach and they're on the ventilator, right? So all the kind of terminology and anatomical locations and all that kind of stuff are very unique to wound care. So we'll kind of get into all that kind of stuff. Um, um, so basically, what is the whole wound assessment? It's a clinical inspection technique to really give us the idea of what's going on with the wound. How is it infected? Is it covered with slough? And then you've got to look at the patient history and physical along with the examination findings and really try to figure out what's going on and what's causing the wound. And to be completely honest with you, a lot of these wounds are multifactorial, right? A pressure wound, by definition, is a lack of blood supply to that area. So it doesn't mean that that's an arterial wound, but that lack of blood supply can be affected by multiple things. Take a pressure ulcer on the heel. It may be caused by that heel sitting on a hard bed, but then once that bed has been turned to a low air loss mattress and they're properly floating the heels on pillows or they have heel protectors, you've really kind of alleviated a lot of the pressure. Are there other things that are causing the wound not to heal? Are there pulses? Do the patients have diabetes? Is the diabetes under control? Are there other kind of factors? Malnutrition? Is there infection that's keeping it there? So really, you're kind of having to do some detective work. A lot of the times it's real straightforward, but a lot of the times it's not. And I find when you start, it can be a little daunting because you want to really classify something real quick. And sometimes you can't quite figure out exactly what it is. And then lastly, when it doesn't kind of fit into one of those broad etiological categories, such as vascular, pressure, diabetic, it may be some form of atypical wound. And if it's an atypical wound, then you typically need a biopsy to really tell you what's going on. And then lastly, it could be some sort of malignant wound where again, a biopsy will be helpful. So like I said, you really want to do kind of this detailed head to toe type of examination that first time. I rarely see people really do a complete full exam. The nurses now at the facilities, they absolutely will. But it's one of those things that if you can kind of try to work it in that first time, you don't want to miss anything. And then looking over their records, if I go to a nursing facility, I always will take the time and I'll go to the chart to look for these common comorbidities. Do they have other risk factors that would, cause a wound to be an issue? For example, I saw a patient this week who had a kidney transplant and he's on tacrolimus. So he's on immunosuppression. He's had this kidney transplant. And if you talk to the patient, you're like, hey, do you have any medical comorbidities? He's like, no, I'm fine. I have diabetes, but that's it. Completely left all that other stuff out. So that really is going to affect the way that these wounds heal. So good chart review, always good. And then ask the patient about, pain. Bianca went over that before, but if this wound is constantly hurting, that may kind of give you an idea of what kind of etiology it is. Or is it just now hurting? Was it comfortable before and now it's hurting? That's kind of a red flag. Why is it hurting? Is there some sort of infection or something else going on? And then you do want to get a list of medications because there's several different medications, including something like tacrolimus that can impair wound healing. And then lastly, get an idea of their allergies. A lot of these patients may be allergic to some of the products. If they have a sulfa allergy, you can't be putting on Clopidogrel, right? It may affect antibiotics that you may choose, topical or oral or IV. So all those basic anatomical locations, going back to anatomy, you got to kind of speak it. It becomes sort of a real easy language between you, treatment nurses, any kind of person that's providing care for this patient. So it can't just be in the bottom of the foot near the first toe. Like that's not going to do, right? It's got to be something more like plantar foot. See, there's a good example. Bottom left foot by the great toe. You want to do left foot, plantar aspect, first metatarsal proximal to the great toe. So basically, your description of the wound, I should be able to see it in my mind without having to see a picture. Not only the location, but as we get into tissue types, different edges, etc. You want to describe that wound so that someone who is in a wound care field, whether that be a nurse, doctor, etc., or a consultant that you're talking to, can actually see what you're seeing without having to see a picture. That's how you should be able to document it, and that's how you should assess these wounds, right? And then when you are kind of doing that initial assessment, look for those really high prone areas: occiput, sacrococcyx, over the knees, malleoli, and the heel. Those are the really common areas for pressure. So any of these patients that are nursing home or at the home by themselves, whether you're seeing them for a wound on their abdomen or whatnot, they're all going to be at certain risks for pressure injury. So if you can prevent pressure injury on your patients, that really helps out the facilities, and it's going to definitely help out your patients in the home. So look at all those areas and kind of notify, the caregiver or the treatment nurse, like, oh, hey, that looks like it may be a potential area. Maybe there's a little bit of redness forming that's at this point blanching. It's not a pressure injury yet. If you can save them from getting a pressure injury, it's a really good thing for that facility, and it's a really good thing for the patient. So your initial assessment, you are the professional. They may want to go into one specific area, and you don't want to take 45 minutes doing some crazy exam, but just take a quick look at those potential high risk areas, and it really will kind of save everybody a lot of trouble. So the first thing that we're doing when we're measuring these wounds is we do basically a size and depth measurement of the wound, and that's how we track the wound's progress or lack thereof, or if the wound is getting bigger. And so this is something that, like Bianca said, our documentation needs to match other people's documentation. There's different ways that nurses do this in facilities, and they have literally like little tablets. They have phones that have apps that measure them. And so your measurements are going to need to line up with theirs. But it's a good way for us, everyone who's taking care of the patient, to get a good idea of what's going on with the wound. And some of the key points is you really want the patient in the same position each time. This is a very easy wound to look at. It looks like it's like on the anterior leg, and it's a big open wound. You've got good light, etc. But sometimes it's on the back of a patient's heel, and the patients are contracted. And then when you turn them over on their right side, it looks like this. When you turn them over on the left side, it looks actually totally different. And sometimes you're only seeing part of the wound. I can't stress it enough. When you actually get in to these situations where you're rolling patients on their sides to look at wounds and they're all contracted, you'll see just how difficult it is. But ideally, you want to get your photograph and you want to get your measurements with the patient in the same position every time, so that it looks the same. So that if I were to look at your chart week after week after week after week after week, I can tell that's the same wound. You don't want to have the patient turned one way one week and then the other week you're taking it from this position and then this one. Try to make it as professional as possible, and it helps tell the story of how the wound's looking. So measurements and photographs alike, try to have that patient in that same position each time. So use these basically paper rulers. We start with the greatest length, which is always going to be the 12 to 6 o'clock position. And then we're going to compare that, or in addition to that, we're going to have the width, which is the 9 to 3 o'clock position. So this does change when you get down to the foot, right? Because the foot will take that 90-degree angle. So now up and down is 6 to 12, but it's on a flat horizontal plane. So it's the same time as the length. And then if it was on the leg, right, that's going to be length. On the bottom of the foot, same idea. So you can get confused. I see it very oftenly confused, where I'll go and I'll see a new provider's numbers and it says 2x5, but it's on the foot and it's actually not 2x5, it's 5x2. So you have to switch that. So pay attention to the 6 and 12 o'clock. It seems simple, but believe me, it definitely, you can get confused. And not only that, when patients are turned on their side and you're doing measurements and whatnot, I have definitely documented wounds on the wrong foot, like the left lateral malleolus, but it's actually the right lateral malleolus or the right medial. And it's amazing that it can get so confusing, but it really can, especially when these patients are really contracted. So spend some time that first time trying to get it right. You don't want to have to go back and change 5 or 6 notes. And that's what I had to do once. Like literally, there's 5 notes that we had it documented on the wrong side. It's embarrassing, and those mistakes happen, but the more careful you are in the beginning, the better. So same thing, just going over the different size orientations there once you get down to the foot. So this kind of wound, you're going to do 12 to 6 as the length, 9 to 3 is the width, and then we're going to get the depth. The best way to get the depth is to basically use, as you can see in the right frame there, they're using like a Q-tip. You can use your curette if you want. You can use the ruler if you want. Doesn't really matter as long as you can get sort of an accurate depth. I find using a Q-tip or a curette's best, doing it just like this. Put it into the wound. I'm using like this pen. I'll put my thumb at the edge of the normal skin like that, and then apply it to a ruler, and then you've got your depth. Seems simple, but it does kind of get confusing at times. I won't lie. So that's just an example of it being done there. And then also on that first time, you want to check for tunneling or undermining. So a tunnel is basically just like a blind sinus tract. So typically it's small. It's going to be in a certain direction. You can probe to see how deep that tunneling is. And if you look at that picture, you're really looking at the tunneling is not from here to there, right? The tunneling is only this part. So if that's on a clock, right, just in the way that this picture is, I would say that's tunneling like 1 centimeter in the 4 o'clock direction, for example. Whereas undermining, like the skin is still intact, but there's actually a cleft, and usually you're looking at a couple areas on a clock. So you could have 2 centimeters of undermining from 4 to 6 o'clock or something like that. In this photograph, you've got this undermining that you can see here. So it's probably like a centimeter at 9 o'clock on this photograph. And if you look at the other side, you've probably got 0.6 centimeters over here at 3 o'clock, for example. And that is something that's good to get the first time too. Usually if there's tunneling and undermining, that means the wound's more chronic. It's going to take longer to heal. Those areas got to fill in. Sometimes you can get infection in those areas. And so if you miss that on the first two measurements and then you happen to realize it on the third time you're seeing it, it looks like the wound is getting worse on your watch, and it really hasn't. You just may not have noticed it. So same idea here, looking at these photographs, looking at different tunneling locations. You want to kind of do it along the clock. Again, 12 o'clock is usually going to be at the head, 6 o'clock at the feet. And you can see they're kind of using this thumb kind of press it there to show how deep the tunneling is. Same idea with undermining. You would take this ruler and or that swab, and I'm sure it's something like here. Let's just say it is, right? You've got about, couple centimeters of undermining going from about 10 o'clock over here to about 12 o'clock, something like that. And if the undermining continued all the way over, like 10 o'clock to 2 o'clock, something like that. And this is how you would document it. You don't need to get this crazy specific. I usually will just say undermining from 9 o'clock to 1 o'clock, deepest at 10 o'clock at 4 centimeters. That would be adequate, if that makes sense. If there's any questions, please, anybody feel free to ask, okay? You're not interrupting at all. And then this will happen in our EMR on its own, but you do get basically wound calculations. Surface area is just going to be length times width, but we actually will have length times width times depth. So we'll actually get the volume of each wound. So you can actually, a lot of the times you may think the wound's getting smaller, or you may think the wound's getting bigger, and it may have gotten bigger length and width wise, but it's actually filling in. So the volume will actually be less. So a depth of 1 centimeter 1 week, and now the greatest depth is only about 0.7 centimeters. Even though the length and width are the same, that wound's actually made significant progress. So that volume measurement is pretty key. And what we like to see ideally is somewhere around a 50% decrease in wound surface area or wound volume over a 4-week period. And if that doesn't happen, doesn't mean you're doing anything wrong. I will say the majority of our patients don't meet that great standard there, but it means that there is something else that's going on that's not being addressed. And that could be any host of things, which we'll get into, but this is in an ideal world, in an ideal patient who's got good nourishment, good blood supply, is being completely offloaded. Diabetes, if they have, it's under control, no infection, right? So if the wound's not getting better, why isn't it getting better? Try to figure out what that is, and then you're going to document that. And then also, it may be that the treatment that you're using isn't correct. So if the wound is basically stagnant for 2 or 3 months and really isn't changing size, and you haven't changed the treatment or documented maybe reasons why it's not getting better, then you're really not doing your job. You as the sort of wound care specialist need to make sure these wounds are getting better or explain why they're not. And there's definitely patients that are on hospice that, their wounds aren't really expected to heal, and that's okay. But you need to describe that. And like Bianca said in the last thing, in a lot of the hospice patients, we're not looking for these wounds to heal. We want them to. But if somebody's albumin is horrible and they're completely malnourished and they're completely bedbound and they've got a giant sacral ulcer, really what we're trying to do is prevent infection, prevent pain, keep them comfortable, try to keep the odor down, which I'll get into the next in the next presentation, different ways that we can decrease odor in wounds, because we really want these people to have some dignity, right? There's nothing worse than walking into a room, and you guys will experience it, where you'll be a couple of rooms away and you can actually smell the patient from a couple of rooms away, and that's horrible. And then family members don't want to be there, etc. It's embarrassing for the patients. So those patients that do have hospice situations where the wound's not going to get better, you still can really do a lot of good for these patients. So getting into the photographs, like I said before, consistent patient positioning and lighting is key. Wounds can really change the way they appear based on the way the patient is rolled, the way that the lighting is, etc. We do want our pictures to all, like I said, sort of tell a story. They should almost be able to be superimposed on each other. Like if you've seen those things on I don't know, any kind of social media where you see things slowly changing or something aging or something like that. It should be like that, where it's like you could literally put the wounds on top of each other in like a stream, and you'd see them getting smaller and smaller and smaller each week, or bigger, whichever way it goes. But either way, you want them to basically be almost superimposable. So looking at different wound etiologies, we're going to kind of go over the main ones, and these are the ones that you'll see the most common. And a lot of the times, once you get used to this, you can really identify wounds like almost immediately. But like I said, some of them are multifactorial. I would say most wounds that we encounter are multifactorial. So keep that in mind, but usually there's one general etiology that's causing the wound not to heal. And that can happen in a few situations where you do have to reclassify wounds. And we'll get into pressure and how you can't backstage, but a wound may start off as a pressure injury, but then once pressure has been completely relieved and you know it's being relieved, now really what's causing it not to heal may actually be lack of blood supply. Like maybe there's really bad arterial supply. Those wounds can be reclassified if need be. So it's always something to think about. But starting with one of the more common ones are venous leg ulcers. Typically, the patients are going to have edema of the lower extremity. They're going to be in that typical medial, just above the ankle location, like you see here. They have this classic sort of brown staining, which we call hemosiderin staining, and they're typically kind of wet wounds, irregular borders. They're usually shallow. For the most part, can be painless, and they usually do have a high amount of exudate. So the hemosiderin is basically just red blood cells that get pooled in there from venous stasis, and the iron from the red blood cells leaks out into the basically subcutaneous tissue. And the byproducts, as macrophages are trying to destroy those red blood cells, the iron basically starts to stain the skin. So that hemosiderin staining is key and is really seen in not every venous ulcer, but in a lot of them. And going against that, just because somebody has hemosiderin staining doesn't mean that it's caused by venous stasis. So you always have to look at other etiologies of what's going on. But that's a really good clue to look, and you'll see it right in that sort of like just below the calf, just above the malleoli. You'll see that hemosiderin staining, and you'll see edema, and that can kind of tip you off to this being possibly a venous. Arterial ulcers. So this happens when you've got basically lack of blood supply to the foot. And we'll get into an exam and all that kind of stuff. But these ulcers typically are going to be painful. Not always, but typically painful. You'll see people that have these giant venous ulcers that are this big that you can put a curette on and clean, etc., and they will have no pain. But a lot of the times when you touch these arterial ulcers, patients will be in pain. That's the thing that can kind of tip you off as an arterial ulcer. They'll also have a history of claudication if they're walking. A lot of these patients aren't walking anymore, so they may not have claudication symptoms. They may have rest pain. But this is where examination comes into play. So arterial ulcers, you're going to have all sorts of specific findings on that foot. You typically have very atrophied muscles, very thin skin, hairless skin, thick nails, and then sort of painful punched out ulcers. That's sort of the classic arterial ulcer. And then when you examine the DP or PT pulses, those pulses will be absent more than likely. So looking at peripheral vascular disease, anybody who's got a wound that's below the knee absolutely needs a good vascular exam. And so I always think anything below the knee, I'm thinking it's arterial until I prove otherwise. So if I can go down and I can feel a very good DP or PT pulse, then I kind of chalk that off my list. It's probably not going to be arterial. Going to be venous, going to be diabetic. Is there some sort of traumatic injury? Is it a surgical wound? Is it a malignant wound? So if I can't feel the PT and DP pulse, then I move up to the popliteal area and see if I can get a pulse there. If I can't get a pulse there, I'll move up and I'll feel for a femoral pulse. If people have significant disease and they've got weak femoral pulses, then the chances are, no matter what's going on, no matter what you do, that wound is not going to heal without some sort of intervention. And so those are patients that you're going to need to consider doing some sort of vascular referral on. So we do want you to do ABIs, and we're moving towards something called QuantaFlo now, which is a little bit different way. You get a toe brachial index or a TBI. but I'm just going to go over classic ABIs. We still do them. If you're in facilities, they usually prefer getting an arterial Doppler, which is just an ultrasound, and that'll show you significant stenoses, but that doesn't give you an actual ankle brachial index. So they're kind of, it'll say sometimes severe lower extremity peripheral vascular disease, or they'll say moderate, or they're so mild. And sometimes they say no hemodynamic significant lesions. And so you're like, oh, well, there's no arterial disease, but that's not true, because then right after that, they'll say monophasic waveforms. So you have to look at the whole Doppler report and take it into like context. Because if somebody's got monophasic waveforms, that means they've got significant disease. It just may not be seen on an ultrasound as a stenosis. So the entire arterial tree is partially blocked, but they don't have a real tight stenosis, or they don't have an occlusion. So you have to look at the whole Doppler report. Monophasic and biphasic signals are not good. And if you can't feel the good pulse, then that's worrisome for any arterial disease. And typically when I was taught in general surgery, if you can't feel a pulse and a patient's got tissue loss on the foot, that's an indication for a vascular surgery referral. An ankle brachial index. This is kind of just sort of like a table showing the different measurements. What you basically are doing is you're getting a cuff pressure of your brachial artery, and you're comparing that to your pressures of your dorsalis pedis and posterior tibialis artery cuff pressure. And so you do ankle pressure over the brachial, and ideally because of gravity, it's going to be higher in the ankle. So anything that is above 1.4, that's typically indicative of calcified vessels, meaning the cuff won't actually completely compress the vessel, so you get a falsely elevated reading. Typically see that with chronic diabetics, but not always. So if it's 1.4, it basically means that's almost a useless test for you, and you're going to need to get a Doppler to see if there are any significant stenoses or obstruction, if it's monophasic, etc. And just for review, in case you don't know, a normal arterial Doppler sound should be triphasic, and you will hear it when you guys do it, but it's just basically a completely normal. If you put it on your radial pulse, you'll see what a triphasic is. Biphasic means that you've got some significant disease, and monophasic is just basically, moderate to severe disease. And there are different sounds that you would get with the Doppler. And so as you look over on the left side of this table, normal is like 1 to 1.4. Once you get down to 0.9, you've got some sort of disease here. That doesn't mean you have significant disease, but there is some peripheral arterial disease going on. And then once you get to less than 0.9, you've got less than 0.9 to 0.7, that's a mild disease. And then you're getting moderate disease once you get down to 0.4 to 0.69, and then less than 0.4 is severe. So once you get down to moderate and severe, you're at a level where typically these wounds aren't going to heal with some sort of intervention. And those patients really need to be seen by a vascular surgeon. Sadly, not a lot of patients will be able to be fixed by a vascular surgeon. Sometimes they've got very small vessel disease just in the lower part of the leg, and there's nothing they can do. And so you do your best to get that wound to heal regardless. But that's a very good description of a unavoidable wound. Those wounds are going to be unavoidable due to this poor blood supply. So you got to let the patients and the patients' families or power of attorney let them know that this is going to be a long process. I've had them see vascular surgery. They can't do anything about it. So we're going to keep the wounds clean. And really, you want to kind of limit how aggressive your debridement is going to be, right? So if you're completely destroying a wound with debridement and there's no blood supply, it's not going to heal. And so typically what I would see is you've got a wound covered with slough and necrotic material. You do an excellent debridement. By the time you're done, it's nice, healthy, granulation type tissue is what you're seeing. You come back the next week and that same horrible amount of slough and necrotic material is back. And all you've done now is you've made the wound deeper and probably a little bit bigger. And then all that nice, healthy tissue that you've exposed is now ischemic again. And so that is like a very good tip off, like, hey, we need to see if we can do some sort of intervention. And if they can't, then really your debridement should be preventing infection, keeping the patient comfortable, and not trying to destroy any good tissue. The key with arterial wounds is not to destroy good tissue, only get rid of bad tissue. And so if patients have no pulses and a mild ABI, as you can see here, you're safe to perform standard wound care and debridement. So you can kind of do that with the estimation that these wounds will get better, that the blood supply is adequate enough for my debridement to actually be helpful. Once you get to moderate and severe, these locations, debridement really now can become problematic. It doesn't mean that you don't do it, but like I said, you have to be very careful about how you document it. It's like I'm doing it just to remove that tissue, devitalize tissue, maintaining all healthy tissue at all costs, trying to prevent this wound from getting infected until they see a vascular surgeon. So, and then if the vascular surgeon can't do anything, then you keep maintaining your treatment, but you want to be a little bit less aggressive and just careful how you document things. Because no matter what happens when you do refer patients to vascular surgeons, they may not always be able to see the patient within a week. Sometimes it's a couple of months. So you have to do what you can to sort of, keep that wound in check until they can see it. So I'm usually sending patients to vascular if there's a lack of pulses and any tissue loss. Like I said, if you've got an ABI or a toe brachial index in a lower extremity wound that's showing that you have even mild to moderate or severe disease, that requires a vascular consult. Because a mild, sometimes those are the best ones, because it may just be a easy endovascular procedure where they can pop open one little stenosis and that wound will heal great. I've seen it with my own eyes. And then if patients have worsening claudication or rest pain, even without wounds, which is not people that we're going to see, but just in general for information, those are also indications for a vascular surgery referral. While you're waiting for that referral is where you want to kind of do what we're talking about. Based on that ABI, level of devitalized tissue, worry for infection, those are reasons to debride. And so there's other ways of debridement, which we'll get into, that are not sharp debridement that can be helpful for these kind of patients. Like Santyl, for example, is an enzymatic debridement that can really help, and that's going to only destroy devitalized tissue. It's not going to affect any good tissue. So that's a good option. We don't use maggots in our practice, but maggots are a great way. They actually have like medical grade maggots that you can get, and they can come and eat away that bad tissue. They don't kill the good tissue, and they've actually been shown to increase granulation tissue, decrease infection, and decrease overall exudate with these wounds. So there are other options should a vascular surgeon not be able to fix this patient. Diabetics, so obviously they're going to have a history of diabetes, but you'd be amazed how many patients say that they don't have diabetes. You go check their chart. They sure do. So chart review is key. And then also, if you can, while you're looking at the chart, ask the nurse, ask the caregiver, how have the sugars been? They almost always know. And it may not be in the chart, but at least they know, like, the blood sugars have been like 250 to 300 like every single time. So this is a conversation you can have with the primary care doc. I am not an endocrinologist. I don't plan on being one. I don't write and change their insulin orders. They usually have them for specific reasons, but it is a conversation you can have, like, hey, we're having trouble with the wound healing. Can we maybe get a little bit tighter control on their sugars? Always do it politely with etiquette. They're professionals just like you. They don't need us being there, like, scolding them. But at the same time, maybe nobody's actually brought it up to them. Maybe they're a lot more worried about treating the patient's pneumonia or something like that, and they're overlooking the sugars, right? So it's just sort of like a gentle reminder. But typically diabetic wounds, you'll see on the plantar aspect of the foot. This is a real classic one here. They typically are surrounded by, a significant amount of callus. A lot of the times they're pain-free if they have neuropathy that's going along with it. And what happens with diabetics in general is they lose sort of their autonomic, you get the sort of autonomic neuropathy as well as sort of the pain neuropathy. But the autonomic one causes kind of wasting away of those intrinsic foot muscles. And so the tendons stay tight, but the muscles are now atrophied. So the foot that usually could hold its position like this based on those muscles now don't have the strong muscle, and the foot starts to kind of bend like this, and you'll see this being the metatarsal heads. So the metatarsal heads will start to bend like this, and that you get kind of a weird arch to the foot, and that puts pressure in different areas, usually along those metatarsal heads and then the heel. And so those are a lot of times you can see where these diabetic ulcers are formed, and plus the patients lose this proprioceptive sensation that we all have. And so they're not moving their foot around in the shoes. They'll stand in the exact same area. So they add pressure onto it. And that pressure leads to these diabetic wounds. And they basically have three sort of subtypes. They're neuropathic, neuroischemic, and then ischemic. So 1/3 of patients that have diabetes are also going to have some form of peripheral vascular disease. And like I was saying before, most wounds are going to be multifactorial, right? And so just because a patient has documented diabetes does not mean you don't check the pulses. You absolutely need to check the pulses, because if they also have an arterial component, that's something that a vascular surgeon could possibly help. So ABIs, some sort of Doppler, toe brachial index, any of those things have to be done on any wound below the knee every time. You're going to hear me say that every time, but believe me, I still look at patients' charts and people are not documenting this. It drives me crazy. But yeah, the neuropathy that diabetics have is significant. They lose that protective sensation. They don't realize that the shoes are actually causing wounds. Like I said, if you have any kind of autonomic neuropathy, you lose those intrinsic muscles of the foot. The foot starts to take a different shape. You have different pressure points. So all those kind of things come into play. A really good way to do it is when you're examining the patient, you don't have to do any kind of crazy Semmes Weinstein monofilament test. You can just actually, while you're feeling around the wound, ask them if they can actually feel you. Typically, they can feel you, but they can't feel pain. And you can actually lightly take the curette and just touch their skin. Does this feel sharp to you? And I guarantee you, if you put it on your foot, you'd feel a sharp edge, but they won't feel it. So that means that they do have some element of neuropathy. And then you can also, do you have burning? Do you have shooting down in your feet? Are your feet numb? How do they feel at night? Does anything make it better? A lot of the times, if it's an arterial component, if the patients hang their foot off the side of the bed, gravity will help get blood supply to the foot, and that will relieve some of their pain. So all these little history and physical things that you've learned back in PANP or medical school really come into effect here. And then neuroischemia, so you've got neuropathy and you've got ischemia. So you don't really get specific wound locations, but as you can see, you see how this patient's toes are basically curled up like that. That's from loss of those intrinsic muscles of the foot. And you can see how the top areas of these proximal joints, those are going to be all at risk right here, here, and here. That's all probably caused by shoes, or it can even be caused by the sheet. If the sheets are on the bed are pulled down too tightly, just as if you're like, I don't know if you guys have recently been in a hotel, but they put those sheets on so tight, you can literally get pressure from stuff like that. And then it's also going to put added pressure on the metatarsal joints down here, and then added pressure on the tips of the toes over here, just from these this neuropathy changes. So all things to think about with diabetic patients. History physical for somebody for ischemia, ask about claudication. A lot of diabetics are still walking. So ask them about claudication. Yeah, do you get, do your legs or your feet start to hurt after you walk? How far do you walk until they start to hurt? Does it get better when you rest? All of those are signs of intermittent claudication. And if they do have that, again, do your pulse exam, because it's going to be critical to determine if these wounds are going to be able to heal or not. Like I said before, 1/3 of patients with diabetes will have peripheral artery disease. Every increase of 1% in your hemoglobin A1C is going to give you a 35 increased risk of having PAD. So they definitely go hand in hand. So definitely, if somebody tells you it's a diabetic wound, that's great. You can document it as such, but do your due diligence and make sure the arterial system's intact. Because if diabetes is completely under control, it's really not a diabetic wound anymore, even though that may have been the initial etiology. What's really causing the wound not to heal anymore is lack of blood supply. Here's just some common appearances. That classic metatarsal joint here, callus around it. And you usually get all sorts of different kinds of debris in here. They have high bacterial counts as well as fungal. So if you are going to use any kind of topical antimicrobial, I usually use an antifungal as well. Charcot's foot, where you basically get all sorts of small fractures. You get that kind of real distinct looking feet here. Ultra is probably from malfitting shoes. You can see how that foot's basically bowed out. That's just putting a pressure point right in these two areas. And then somebody who's got actually more, this is more of an ischemic wound, right? You can see that you've got all this dead tissue here. And this is a perfect example of what happens with an arterial type diabetic wound. You get this ischemic necrotic slough material. You can clean this all off. And I guarantee you, if the blood supply is not good, even though it's completely pink when you leave, you come in the next week, it's going to look the exact same. And you're going to look at the nurse and go like, what have you been doing? And it's not their fault. All you have done by debriding it is exposed good, new, healthy tissue that now doesn't have blood supply to heal properly. So those are people that need to see vascular. Dry gangrene, you guys will see this occasionally. Obviously, if you see this and the patient is not a hospice patient, this is never going to live. There's really no significant debridement that you can do to help this. This needs to be taken, sent to the hospital, and they need to probably amputate it. Now, I see these all the time in nursing facilities. Typically, they're hospice patients. So they don't want surgery, and the family just does not want anything aggressively done. You can sort of debride these edges that you see here and keep those clean. You want to keep any infection out of there. And you really just have a mummified foot right there. So the two basic outcomes are that eventually this is going to transition into a wet gangrene, and then you've got an emergency. And if the patient's on hospice, again, there's not much you can do. You can talk about IV antibiotics versus just letting the patient go from sepsis, or they auto amputate. And more often than not, you're not seeing a full foot like this. It may just be the third toe that looks like this, and they auto amputate all the time. So you just kind of cover it with betadine, keep it as dry as possible. And then eventually one time when you're kind of examining it, the toe will literally fall off in your hand. Make sure you send it for pathology, right? But that's how you would treat these sort of dry gangrene patients if they are hospice. And if you do see wet gangrene, that would look similar to that, except you're going to have horrible odor. The patient's going to be febrile, tachycardic. They usually have like a significant amount of pain. There'll be perineal drainage coming out of there. That's an immediate transfer to the emergency room. A cold foot and wet gangrene are an emergency room transfer every single time. There's nothing that you can do except start IV antibiotics before, if you can, before they even get transferred to the ER, and then get them to the ER as soon as possible. So now getting into pressure injury staging. So this is kind of like one of the most common things we're going to do. It seems pretty basic, but there's a lot of things that I didn't know about this as a general surgeon, and I didn't really know the intricacies of it. So I'm going to kind of go over it, and please, like I said, feel free to ask any questions. But really, why do we stage these? It really gives us a good idea so that every clinician, everyone taking care of this patient really can understand the extent of the injury, know exactly what we're dealing with, and know exactly what's best to do to prevent this from getting worse. So it starts off with partial thickness, and then those eventually go to full thickness wounds, and we'll get into each stage here. So this is just sort of a breakdown of all of them, and then we'll get into each one specifically. So stage one is basically a partial thickness wound. You just get non-blanchable redness. So you'll see patients that have pressure points that are exposed. In those pressure points, will actually have some erythema. If it's blanchable, that's not a pressure injury yet, but it's on its way. So that's something where you need to try to intervene as much as possible. And these are things that you see all the times in nursing homes where you could salvage that area if you catch it, or if the treatment nurse catches it before this turns into an actual pressure injury. That's where you want to float it. Get a low air loss mattress, some sort of protective bed, heel protectors if it's on the heels, float the heels, etc. Stage two is where you actually do get breakdown of the skin. It's only in the subcutaneous tissue, in the skin level. It's not down to the subcutaneous tissue yet. So that's stage two, and we'll get into it in detail. Stage three over here is where you've gotten through the skin and now you're into the subcutaneous tissue, but not down to muscle and bone yet. And you will get slough, necrotic material, etc. in a stage 3. There's no slough at all in a stage 2. Once you see slough on a wound, that's a stage 3. So there are some studies showing that you can actually get granulation tissue in stage 2, but that's kind of not, for the most part, widely accepted. So if you're seeing granulation tissue or slough, that's going to be a 3. The stage 2 is always 100% epithelial tissue at this time. And stage 4 is now it's gone through the skin, into the subcutaneous tissue, and gotten down into muscle or bone. And I'll be honest with you, depending on locations, this can be deep or it can be actually fairly shallow. If you've got a pressure injury on the ear, on the bridge of your nose, on the occiput, those are areas where there's very little subcutaneous tissue. And a lot of the times those go directly to a 4, but we'll get into that. And these last 2 categories here, so you've got deep tissue injury or DTI. And so that's where on the top of the wound, it could look like it's just a stage 1, but there's typically a lot more bruising. So the skin is actually intact, but you've got bruising, purplish tissue below the skin. So you know there's injury that goes deeper, but you don't know how deep that's going to go yet. And so that's just deep tissue injury that's going to do one of 2 things. It's either going to completely resolve and you're safe, the skin stays intact, excellent for the patient, or that area of pressure that's manifested by that bruising, discoloration, etc., eventually dies from ischemia, from pressure, and it turns into an unstageable. So it's covered with either necrotic or slough material, and it's unstageable because you don't know how far it goes until that slough is removed. In this picture right here, you can see the necrotic tissue goes all the way down to the muscles and bone down here, but that's not always the case. Sometimes that necrotic tissue is only limited up here, the subcutaneous tissue. So once you debride it, you're like, okay, it's not unstageable anymore. It's a stage 3. Or you've debrided it down and you can actually see muscle or bone, and that unstageable is now a 4. So once you debride an unstageable pressure injury, it's either going to be a 3 or a 4. There's no other possibilities. So if a nurse is like, well, no, isn't that a stage 2 because it's only like 2 millimeters? It doesn't matter how deep it is. If you've got slough or necrotic material that you're removing, that's going to be a 3 or a 4. Depth does not mean stage 3 or stage 4. It's not depth. It's what is being debrided. So subcutaneous tissue and skin, that's a 3. Once you get down to muscle and bone, that's a 4. So examples of stage 1, like I said, this is non-blanchable erythema. And actually, it's pretty evident. If you were to push on this heel right here, as you guys all know, you push on your skin, you get a nice little white thumbprint, and that thumbprint fills in with blood. That's blanchable. If you push on it and the redness stays exactly the same before and after you put pressure on there, then that is a stage 1 non-blanchable erythema. Skin is intact. So it's a very kind of easy thing to identify. And ideally, you don't know. Sometimes these stage 1s can actually have a lot more damage. You'll see when we look at the photographs of DTI how it looks different, but a stage 1 and DTI can really appear similar, but DTI is typically going to have that dark bruising under this. You can see this kind of redness here, but you would see a significant amount of extra bruising under there, and that's more significant, and that's what I would call it DTI. Especially if a patient is being seen by you for the first time. The patient's coming right back from the hospital, and they're having you look at this wound, and it looks like this or that. I think that's safe to call that a stage 1. When you see DTIs, you'll see the difference, because if it is a DTI, you want to properly diagnose that, because a DTI, like I said, is either going to turn into nothing and heal on its own, or it's going to become an unstageable, which means by definition, it's going to be at least a 3 or a 4. So you don't want wounds in any home or facility going from a stage 1 to a stage 3 or a 4 under your watch. And they don't want that either, if that makes sense. So the proper diagnosis from the beginning is pretty critical. Stage 2 is where you got just into the skin, right? Into the dermis or the epidermis only, not into that subcutaneous tissue below. So they kind of present as stuff like this. You can see this here, just basically almost like just an abrasion of the skin. But you can see this whole area of sort of darkened tissue. That's all some pressure injury. And then these areas are where skin is actually broken down. So that right there would be a stage 2. At the bottom here, again, you can kind of see this whole area of redness. That's all pressure. That could also be a little bit of moisture-associated skin dermatitis, right? MASD, which we'll get into as well. But this little area here, that's the stage 2, where the skin is actually broken down and you have a partial thickness wound. Other examples here, same idea. You can see all this kind of red pressure, this MASD, and then you see the skin broke down right in here. And that is kind of one of the critical things that you may end up with in facilities where the nurses are like, isn't this more MASD, not really pressure? And that's going to be your call, really. And they may be right. A lot of the times, MASD, or moisture-associated skin dermatitis for patients that are incontinent or sweating or stooling themselves, will cause this sort of skin damage that you see here. And then that top layer of epidermis and even into the dermis can get kind of basically pulled off either from too aggressive cleaning, right? If you're like cleaning off like dried stool, or even if it's diarrhea, like you see like on baby rashes and whatnot, that's not from pressure. That's from too much moisture, and the skin is now damaged from so much moisture. And because of cleaning it, you've actually denuded the top layers of skin. So MASD and stage 2s really can be hard to differentiate from each other. And this is where sometimes you do want to take the lead, and kind of make that decision, or defer that decision to the treatment nurse. Like, what do you think? I mean, you've been seeing this patient all week. Is there a reason for it? Now, if the patient's got a colostomy, so they're not stooling themselves, and they've got a catheter, and they're trying to call this MASD, that becomes a little bit harder to document, right? Because there's really no reason besides sweat and stuff like that that would be causing it. And that's probably more likely a stage 2. But a lot of wounds, like I said, are multifactorial, and they really like to sort of mimic each other. So it really requires kind of being a little bit of a detective about it and trying to figure out exactly what's going on. The more you do it, the more confident you'll be with your decision. And I can tell you now, I still look at it and I'm like, I don't know. I don't know if that's MASD or stage 2. Like, is this patient got diarrhea? What's going on? If they've had diarrhea and stuff for a long time, it makes sense that this could be MASD. Other examples of stage 2 would be an intact or ruptured blister, serum filled, that you can see here. So that basically is serum or fluid that's been trapped under intact skin. But as soon as you were to sort of drain that, you know exactly what's under all those kind of blisters. I'm sure all of you have had blisters before. And right under there is that nice pink, fresh skin. And that is basically the same thing as a stage 2. So any kind of intact blister, even though that skin right here is intact, that's not a stage 1. The skin layers have already been damaged, so that was going to be a stage 2. Things that you're not going to see in a stage 2, like I said before, any kind of slough that you can see here, any kind of granulation tissue, which you see up here, that nice pink, healthy granulation tissue. If you're documenting granulation or you're documenting slough, that's not going to be a stage 2. Any kind of eschar or black scab, that's not a stage 2 either. And then lastly, skin tears. Skin tears, just like MASD, you see this nice healthy layer of skin. It's just through the dermis or epidermis, and that is not caused by pressure, but skin tears are typically caused by trauma, right? So either they bump into a desk, they've got that old, really thin skin, anything can tear it, and that's not pressure. So you have to look at what caused the wound. Was it some sort of trauma, or under here, right? Here's other areas of trauma. MARSI, for example, or medically adhesive related skin injury. I've seen it happen all the time where you've got a nice stage 3 pressure injury on the sacrum, and they've got an acrylic dressing, and that nurse or you, I've done it too myself, sadly, but it happens. You take that dressing off a little too aggressively and you just rip the skin. So you've not caused a stage 2 ulcer, you've just caused a skin tear, and that's a medically adhesive related skin injury. Or like we said, MASD, moisture associated skin damage, incontinence associated skin damage, intriginous dermatitis. So MASD and IAD are basically the same type of idea, just too much moisture. They can lead to basically skin changes and eventually skin breakdown, but it's not related to pressure. And then intertriginous is basically just, under your armpits, under the pannus, in between the legs, where you've got too much basically sweat and too much moisture, and that can cause skin breakdown. Again, that's not from pressure. So pressure injuries, and the only injuries that you're going to quote unquote stage are going to be pressure injuries. They do have staging for diabetic wounds, but that's not the same. It's not stage 1, stage 2. It's a little bit different, and that's for a different time and a little bit kind of higher knowledge. And you can also classify arterial disease in stages 2. But anything that we're going to stage, like on our shorthand notes, it's only pressure. Stage 1, 2, 3, 4, unstageable or DTI, that's all going to revolve around pressure. So if it's not caused by pressure, but it's caused by moisture, or it's caused by some sort of skin tear, that's not pressure. That's either a skin tear or some form of MASD. So stage 3, and you can look at this. This looks like it's barely a stage 3, right? Almost from a stage 2 into a stage 3, but you've gotten through the epidermis and dermis, and now you can actually see in some of these wounds a little bit of that yellow slough, and you can see granulation tissue. So once you get through the skin into the subcutaneous tissue, that's not now a stage 3. In stage 3s, we typically debride. Stage 2s, you do not debride. It's clean epithelial tissue, you do not debride those. So stage 3, you've got damage to the epidermis and dermis, and then you've got visible subcutaneous tissue. Here you've got slough and some granulation tissue. You can also see this additional redness from pressure around the side here. There also may be some MASD associated there as well. But once you see that subcutaneous tissue, granulation tissue, or slough, that's now a 3. And right as it says here, must be visible, subcutaneous tissue. This is a little bit more extensive. And this is where, I would actually look and go like, is this a 3 or a 4? I can't totally tell, to be completely honest. Am I looking at muscle? I don't know. Is it just subcutaneous tissue? I'm not quite, possibly. Could be. Who knows? You have to kind of know the patient. But in this case, this is all nice, healthy granulation tissue that you can see here. And then right here is actually fat or subcutaneous tissue. So that's why they're calling this a 3. There's no real obvious muscle that's there. So that's 3. And then what you may also see here, granulation tissue, necrotic tissue, slough or eschar, epipyle. That's these kind of rolled edges you see here. That edge is actually kind of rolling under itself like that. That's called the epipyle, and that's going to increase the time that's going to take for that wound to heal. And there probably is some aspect of undermining or tunneling that you can also see in this wound. Right here, you'd have to probe it, but there may be some tunneling there. And then I can almost see it here. You can see a shadow, but I guarantee you there's a little bit of undermining right there where you could put a probe and kind of go right over there from about 12 o'clock to 2, maybe even down to 3, right? So that's how you would measure that undermining. And if there was a tunnel right here, then you could measure tunneling. So the 3 is going to have tunneling and undermining just like 4s. You do not want to see muscle, bone, tendon, ligament, cartilage, or fascia. Any of those things mean that it's a 4. And what they're kind of seeing right here is you've got this clean, healthy scar there, healthy granulation tissue here. And then down in this area where you've got all sorts of slough, we're getting down to areas where there's definitely some muscle involvement. And then under here, you can probably see that there's a little undermining or tunneling that's going on there. So if you see any of these things, then that's going to be a stage 4. So full thickness through the skin, through the subcutaneous tissue, down into muscle and or bone. So that's the definition of a stage 4. We'll kind of go over some photographs, and you will definitely be able to identify these ones. You can see here muscle in this area. This looks like some granulation tissue over muscle there. This here, you can almost see the muscle is like literally almost popping out of the wound. And you can see here, this is going down the muscle here. some necrotic material and slough. This is the anus right there. So this is just sacrococcyx. This is a good example in this photograph where I'm circling right now. That's DTI. And I hope you can appreciate the difference there between that and maybe a stage 1. So stage 1 is just a non-blanchable erythema, but you can see that kind of purple change under there. That's going to grow. There's going to be something deeper that's under there. And like I was saying before, depth does not matter. One of the nurse practitioners that asked me, well, like if it's 0.6, does that mean it's a stage 4? And not always, right? Sometimes if that wound is on a bigger patient, there's a lot of subcutaneous tissue, you can have a centimeter, sometimes 2 centimeters deep before you actually get to the muscle. So that's technically actually a stage 3. The opposite of that is something on the ear where there really is no subcutaneous tissue, and you've got something like that. So this looks more like, to be completely honest with you, more of an unstageable. It's kind of covered with some eschar and some slough. But if you were to debride off this scab, as opposed to calling that a 3 and it's on the ear, that's something that you would call a 4. Most things on the ear, bridge of the nose, occiput, once that unstageable eschar or slough has been removed, you typically just put that right to a 4. So unstageable basically just means that it's covered at least 50% with slough or necrotic material. So you cannot determine the depth until you debride it. And there will be cases that you guys see here later that you don't want to debride unstageables. Usually on the sacrum, something like this, you don't want to take off all of that slough, debride that all off. And then depending on how deep that goes, if it's just in the subcutaneous layer, then that's going to be a 3. If it goes deeper, like you can see in the picture below, this area up here, I could safely say that's probably at the 3 level, not really into the muscle. But once you get down here, you've got evidence of muscle down there. That's pretty deep. So once you remove this slough and eschar here, we'll let you determine the depth. So once you debride an unstageable, it's no longer an unstageable. It's either a 3 or a 4. However, there are times where you are not going to debride these, and we'll get into that. So basically, great examples here. You can see this whole slough and necrotic tissue here covering this wound. We don't know how deep that's going to go. Or this wound down here, we have no idea. So the nurses may say, oh yeah, we have an unstageable, but these are ones where on these areas, you definitely are going to want to debride that and get that clean. So after you do such said debridement, it's going to be either a 3 or a 4. And then here's some unstageables that you may not want to debride. So we're not always talking about sacrococcyx. And this is where like my general surgery training and my mind didn't work. Like I always thought pressure injuries were just on like the sacrum. I don't know why I thought that, but that's not the case. A lot of times you can get them on the foot. You can get them on the malleoli, ears, everywhere on your body. Anywhere there's a possible pressure point. It's unbelievable, actually. You'll be surprised at what you see. But looking at eschars, or these sort of black scabs, this is a nice, stable eschar, and so is this. They're healthy, they're hard, the edges are still attached, there's no odor, there's no drainage, there's no erythema, they're stable. And what they are is basically a biological dressing, right? So they can stay on there. I don't touch a stable eschar, especially on a foot, unless you need to. And when you need to is when they start to become unstable. The edges are falling off. You're getting drainage. You've got odor. The patient's having new pain. So once an eschar is now unstable, that eschar should be removed because it's just going to turn into infection. So also, we're down on the foot, and I'm going to say it again, you need to do that vascular exam, right? So if you were to do a vascular exam on this foot right here, and you've just got bounding pulses, you can definitely make an argument for unroofing this and saying like, this is dead tissue. It's not going to get better without debridement. I'm removing it to accelerate wound healing. That's totally fair. I would not ever remove these if I'm not feeling a pulse, right? If you're not feeling a pulse, then you'd get an ABI or a Doppler, and depending on those, you definitely would want to refer to a vascular surgeon. because these can stay stable for weeks to months, and they can get that blood supply to the foot better. Then once the blood supply to the foot is adequate and you're now feeling a pulse, or your ABI is now up to say like 0.8 or 0.9, then you can safely remove these should you want to, or you can kind of keep treating them with betadine until they become unstable. The issue is that once they become unstable, it almost always means there's some infection there. So if there is a very good pulse and these things have been there a long time and you know there's deep tissue involved, sometimes it's better to remove these before they get infected. And you'll see this, like you can remove this and it may only be about 3 millimeters deep. Once it's something where it's unstable and you've got pus coming out of it, stuff like that, now you've got an infection to deal with. It may have gone down to the bone. So anything that you're doing in terms of debridement, you always want to kind of have an idea of why you're doing it and document why you're doing it or why you're not doing it. So pressure injury with the addition of vascular injury is very hard to deal with. So if the patient's got poor blood supply, do everything you can to get that blood supply adequate before doing debridement. If it's an unstable ulcer, I had a patient literally last week had something very similar to this on his heel. It was hanging off. There was like a little bit of pus coming out of it. The previous provider had said that it was a stable eschar. I'm not sure if it was or not. That has nothing to do with them. But when I saw it, when you see some infection there, and it smelled bad. And the eschar was soft, it was boggy. I was like, I'm taking this off. So I took it off. He's got no pulses, so I know it's not going to heal. He's seeing vascular surgery this week. So thank God they got him in to see vascular quickly. But you just want to remove it so you can get the infection taken care of, start them on antibiotics, and then let's see if vascular can get him better. And if they can't, then this is something that I will slowly have to try to nurse back to health. So again, stable, dry, intact edges, it's adherent, no bogginess, no fluctuance, no erythema, induration, maceration, edema, and no warmth. So this is a nice, hard, stable eschar. Like I said, you can definitely make an argument for removing it in a patient that's got really good blood supply. Same thing if it's on the sacrococcyx area. If you're confident that the pressure has been relieved, they're in a low air loss mattress, the family or nurses are on a really good schedule to off-weight the patient, you can safely debride that with your intention of getting rid of the dead tissue to accelerate wound healing. That is what we do. Different, right? If you don't have good blood supply. If you're suspecting ischemia, you've got a nice stable eschar like this, you leave that eschar intact, see if vascular can take care of it before you do any debridement. Versus an unstable. So if you've got unstable eschar, vascular exam does not matter at that point. You need to get rid of the infection. You want to prevent osteomyelitis. You want to prevent any necrotizing infection to that foot. Or if it's on the sacral coccyx area, if it's unstageable and you have an unstable eschar, then you want to get rid of all that dead tissue because all it's going to do is get infected and get worse. And examples of an unstable eschar, it's moist, the edges are peeling off or lifting, it's boggy, and you'll feel it. It literally feels like wet paper or like wet, I don't even know, like a banana peel, right? Like that soft kind of like almost gooey feeling, like that needs to get off. That's not going to do the patient any good. That's not acting like a biologic dressing. All that is doing is creating worse and worse infection under it. And typically, you can imagine this is like this black cap on top of something. Now you just got this infection brewing, and it's going so bad that it's now like literally popping out from around the edges. And that's really what's happening. So once you unroof those, you may have a bigger problem under there. And that kind of boasts the argument that if somebody does have good blood supply, maybe you should remove these dry eschars. So that really kind of depends on your practice, how comfortable you are, and also patient's desire and how much pain the patient's in. But once it's unstable, you really got to get it off. The peri-wound or the area around the wound will be erythematous, there'll be induration, maceration, edema, exudate, temperature. Patient may have fever. It may just be warm to the touch. So you kind of gotta have to make that judgment. Sometimes eschars, aren't quite so clear. They're right in the middle of being unstable and stable, and you're kind of like, I'm not really sure if I should remove this quite yet. The patient doesn't have any pulses. And so in those cases, sometimes what I do is, we'll get into it in detail, but I'll score the eschar with a scalpel and use Santal or something like that, Medi-Honey, to soften up the eschar with the intent on removing the next week. Because once it starts to show signs of instability, it's going to have to come off. It just matters when. And so if the blood supply is bad, you're waiting for vascular, that's a good temporizing measure to soften it, makes it less painful for the patient. And then you can plan on removing it the next week. Unstable eschars in patients with vascular problems, like I said, you have to remove it, reduce that risk of infection, reduce the risk of that infection getting down into the bone. So any unstable eschar really should be removed, regardless of vascular supply, but just document, yeah, patient's got bad blood supply. The reason I'm removing this eschar is that it's unstable, there's odor, there's drainage, I'm referring him to vascular surgery or her, etc. So just always document why you're doing what you're doing. This is just an example of debriding an eschar that basically looks, I can guarantee you this thing is like that hard, but you can see the edges are starting to lifting. There's probably some drainage coming around the end. So you can take it off all in one piece like this, or you can kind of do what I said before about the Santal and the scoring, which there's a slide on later that we can kind of go over. But here's just some examples of when you have an unstageable pressure injury. A lot of the times you can see in the sort of progression of these photos, you don't get everything off, the first time. So you're removing just the most annoying parts or most infectious parts, worst parts, most worrisome parts. You can see here, there's still some necrotic material here and some slough, and then the week following, they were able to get everything off in terms of the necrotic material, but still slough. And then eventually you debride away this slough, you've got a nice granulating wound, and then once the wound is actually granulated, the wound will actually start to heal. So this is something to keep in mind when you talk to the families or the patients, that, hey, things are going to get worse with an unstageable before they get better, because you don't have any idea that this is going to eventually get that deep. And sometimes it's actually much deeper and bigger. And they're like, what are you doing? You're making this wound worse. And so if you have to play catch up, that's never good. Just go like, hey, I have no idea how bad it is under this, but there's infected material that needs to get off. We need to remove it. The wound's probably going to get bigger, but once we get all the dead stuff out, then the wound can actually start healing. It's really not going to start healing until we can get that all off. It'll probably be getting bigger, just so that they're aware. The more that you can keep everybody in the loop, and that includes like the primary as well as the treatment nurses or caregivers, etc., so they don't think that you're just hacking away on a patient, because you're not. What you're trying to do is get rid of all this dead stuff so the wound can actually get better. But trying to remove all of this in one sitting is going to be very difficult. Honestly, if you see something that's this bad and then they've got infection in the subcutaneous tissue all around here, sometimes that's really better dealt with in the operating room. So that's another one of those judgment calls. Feel free to ask me or your supervising provider. This is unstageable, so you've got granulation tissue present here. You've got slough, yellow stuff here, and you've got all this eschar, kind of dry eschar here. And so really why this is unstageable, you can tell this is already probably a 4 just by this area, but it's covered at least more than 50% by slough and necrotic material. So original diagnosis would be an unstageable, and then once you've done your complete debridement, you can see you've gotten down through fascia right here, and then into muscle here. So that would be a stage 4 after your debridement. So deep tissue injury, this is what I was saying before. If you were to have just this little circle area, that's all you've got, you could probably safely call that maybe a stage 1. But you can see all of this bruising here and this deep purple right in here. That's all deep tissue injury. And then this picture also has 2 examples of unstageables, right? Both of those areas of DTI have broken down. The skin is now broken, and you've got them covered with slough / necrotic material. So you've got 2 unstageable ulcers, and then this big area of deep tissue injury. And this is another thing when I talk to the families, I always go deep tissue injury or unstageables. I like to compare it to I think the next slide is this, says it. Yeah, tip of the iceberg. Because you have no idea how bad it's going to get until you debride. So expectant management is critical. So they understand things are going to get bigger, the wound's going to get deep. It may go all the way down to the bone. You don't know until that tissue is removed. And if they know that before you start cutting, I can tell you it is all the difference in the world in terms of how much they're going to trust you. Because if they see, for example, just this, and then 2 weeks later, it looks something like this, they're gonna think that you're doing something horrible, right? So always let them know it's just the tip of an iceberg. Like this wound right here, especially with all this bruising, I bet if you were to unroof this, you'd have a wound that goes undermining all the way down to these areas. And they need to know what that debridement entails before you do it. That's all the process of a proper informed consent. And they need to know that things are going to get worse before they get better. And, this isn't all on you. This is on the nurses. The wound is already there, so it's not your fault. You're there to help it, and you have to describe exactly what you plan to do and how bad it may get. I don't think you have to go like, hey, every patient who's got a wound here needs a colostomy. It's not something like that, but you need to at least let them know kind of what to expect and how bad it may get before it starts to get better. And these things can take 6 months to a year to heal, sometimes even longer. So it's a real long process. And so that first conversation you have with them, spend that extra 20 minutes and make sure that you guys are all on the same page. Make sure that they trust you. A trusting patient and doctor or PA or nurse practitioner relationship is the best way to prevent you guys from having unneeded lawsuits or complaints. It's just so that everybody's on the same page, right? Because these are all people's family members. Imagine it's your mother or your father, and you have no clue about medicine, right? And you see a wound that looks like this, and then 2 weeks later you're looking at this. Anyone's going to freak out about that. So you really have to kind of, get them in the mindset of what's about to happen. Here's a good example of a DTI on the heel, right? We saw that stage 1 before, which looked a little bit more like this color. You can see now this is different. See how purple it is there? Skin is intact, but all that purple damage, that's going to go deeper. Now, if this is properly offloaded and the patient has good blood supply, this may resolve on its own, which is just awesome. Or it may turn into one of those black eschars on the heels like we saw before. And if it becomes one of those black eschars on the heel before, you're left with, is it stable? Is it unstable? What's the blood supply? When am I going to debride it? All those same questions will come back up. Kind of a poor example of it right there, to be totally honest with you. Medical device related. So all these patients that you see in nursing facilities and in their homes have a laundry list of these medical devices. CPAP machines, BiPAPs, endotracheal tubes, right? Cervical collars, trachs, IVs, NG tubes. I don't know if you guys have experienced that where patients have an NG tube and it's like pulled up their nose like that and end up with a pressure injury right on their nose. O2 cannulas, you get pressure injuries right back here on your ears. You can get them in the nose if they're pulled off to the side like that. Pulse oxes, very common, especially if they put them down on the feet. Catheters can literally tear through. I've seen it like over time, tear through a penis and literally just bisect the penis. I've seen women's urethra stretched out to like this big because there's so much tension on the catheter. Also, they lay on the catheters. So if the catheter is stuck under one leg and they're not moving the patient, and it's been like 10 hours, 12 hours, they'll have a nice purple strip where that catheter used to be. That's medical device related pressure injury. Negative wound vacs, absolutely, especially if you put them on the sacrum. I don't know if you guys know, but they have like a small, like the suction thing is about this size, and there's like usually a little knob where a tube comes out, and that can cause pressure. So if you're going to be putting a wound vac on somebody on the sacral area, it has to be bridged out to the side. And if they get to the point where you guys are doing any of that, we can kind of go over that in detail to make sure you do it correctly. Wheelchairs, walkers, splints especially. You'll have orthopedic guys putting splints on patients saying, do not touch this. And then, you can kind of peek under there and you can see a big pressure injury forming. I usually let the primary care know and then try to get in contact with the ortho guy or girl to let them know, like, hey, this thing is causing some problems. Can we remove it? Can we pad it differently? Can we place it differently, etc.? But very common to happen. And those are depending on what the patient needs it for. A lot of the times those can be unavoidable. But as I just said, with like an NG tube, pulling up your nose, they may need that NG tube, but they don't need it pulling up their nose like that. They may need that Foley catheter, but they don't need it pulling off to the side or ripping up and causing urethral injury. So they're not always unavoidable just because it's a medical device. And then lastly, there's mucous membrane pressure injuries. These aren't staged. This would be like on the inside of your nose from a nasogastric tube, on the inside of the rectum from a rectal tube, inside of the mouth or in the throat from an endotracheal tube, something like that. And because of the way the mucous membranes are, you usually just end up with an ulcer. So they're unstageable. You don't do stage 1, 2, or 3. It's just a nasal-related pressure injury. So moving on to different tissue types. I kind of went over them a little bit by showing you guys those wounds, but when we document them, these are the main tissue types we're going to be looking for. So first, take a look at the wound base, a look at the entire wound, get an idea of what kind of tissue you're dealing with. And use all your senses if you can. Feel it. Feel if it's adherent. Feel if it's hard. Feel if it's soft, especially if you're dealing with an eschar, right? An eschar that's hard like a table, that's a nice stable eschar typically, versus something that's just like, soggy cereal, that's going to be boggy, that's unstable. Smell is key. Making sure that there's kind of infection or whatnot. But classic granulation tissues, that pink tissue that we all see, made up of capillaries, extracellular matrix, it's usually, kind of bumpy or cobblestoned. In these pictures, it's almost hypergranulation, like almost it's growing too much, which sometimes can indicate infection. But just for the purpose of this, granulation tissue is that nice, healthy pink tissue that we typically want to see. These are hypergranulations where you can see it literally growing over the edges of the wound here and down here. So hypergranulation tissue is granulation tissue just kind of basically on steroids. It usually will happen if there's infection present or if it's just too exuberant and you actually kind of do need to treat that. Silver nitrate sticks treat it very well and can basically kind of get that back to nice, normal, healthy granulation tissue. If silver nitrate is hurting the patient too much, topical hydrocortisone or something like that can also help. But the problem with hypergranulation tissue is that it will not allow epithelial tissue to grow over. So the wound will not heal. So when you see wounds that are like totally granulated and they remain the same size for like weeks to months, and you're like, what the fuck? What is going on here? Like, why is it not getting better? A lot of the times it's hypergranulation tissue and the epithelial tissue can't make its way over the wound. So you have to deal with it in one way or another. And another reason, as we'll get into later, is that a lot of times hypergranulation tissue is a reflection of increased biofilm or bioburden. So there's actually, although you can look at this and that doesn't look infected, there may actually be a really heavy bioburden that's causing the hypergranulation tissue, and it's just not healing properly. So you actually need to breed away some of that biofilm. Then there's granulation tissue that's basically unhealthy, right? Pale, doesn't look good. You can see here, this is like hypergranulation tissue that's got like a hypogranulation tissue, sorry, that's got some increased pressure. And then basically you've got biofilm there, high bioburden. You can see you've got all this slough and stuff here. You've got basically a good view of what an unstageable looks like right here, right? You can see this eschar out here. Look at how small that little eschar is, right? And then look at all the dead tissue that's under it. All of this is dead. And if you were to measure just this, and that actually, I ain't lying, that looks like a stable eschar. That looks like nice, hard black tissue. But look at all the dead tissue that's beneath it. Just another reason why a lot of the times stable eschars, you have to kind of think, do they need to be removed? Because if you're going to debride this kind of wound, all of this needs to be removed. All of this slough here needs to be removed. Here, here, all this stuff. All of that needs to be debrided up here. And then I would lightly use a curette on most of this hypogranulation tissue here to kind of get rid of that biofilm. Just because it looks like kind of like pink doesn't mean it's healthy granulation tissue. A lot of times you've got really high bacterial loads that are down deep in this tissue. And even if you take a tissue culture, you're really just going to be taking, a wound culture, you may just be getting this top layer of stuff, which is inaccurate. You want to get the stuff that's below. We'll get into wound cultures later. So granulation tissue, overall, that nice pink tissue. We've all seen it. And then this is slough, just devitalized tissue, usually white, yellow, sometimes gray. It can get kind of green coloring depending if it's starting to get infected. But this is a classic heel ulcer with slough. I can guarantee you, I bet my life on it, before this looked like this, there's a nice, healthy black eschar on top of this. And so when you take out that eschar, this is what you're looking at, especially if they've got vascular problems. And then if they do have vascular problems, you can chip away at this all you want, but this keeps coming back. It's very frustrating. And so that's why if you can get them to see vascular and they can revascularize it, you can take this off and then it'll start granulating and start healing. So it's really good. But that's a really good example of what slough looks like. And then necrotic tissue is basically just that dead black tissue. All of this you see here. And then some of this yellow stuff you're seeing in here is a combination of necrotic tissue and slough. And so what we like to do is put percentages in there. So let's look down at this lower wound here. You see this is necrotic tissue here. So you could say something like, 40% necrotic. You see some areas of slough here and there. So maybe 10% slough and then 50% granulation. Whereas up here, you've probably got something more like 60 to 70% necrotic, 20% slough, and then like 10% granulation tissue, something like that. So we always want to use percentages when we're doing this. I'll kind of get into it when we do our shorthand note. Percentages will always be in groups of 10. No need to do 75, 25. It just confuses everybody. Different kinds of adherence. And this is key when it comes to debriding. Some of it is just really non-adherent, easily removed. Some of it's loosely adherent where, you got to use like a curette, sometimes a scalpel, and then there's the firmly adherent. So loose adherent or non-adherent tissue, like that stuff you're seeing in this left-hand corner, you could almost take that out with gauze. Whereas something that's a little bit more densely adherent, like here, or loosely adherent, is something like this is, you got to get a curette in there, maybe even scissors or a scalpel to try to get that out. All this good granulation tissue. Looks like there's some slough here. And then this white here. I'm just going to try to use as much as I can with these photos. That white edge there, looks like there may be a little bit of maceration around the edge of the wound. It doesn't look like it's maceration from like the patient soiling themselves. It looks more like maybe the dressing isn't changed frequently enough. So these edges are getting macerated. By macerated, I mean like, if you're in like a pool too long and your hands start to get pruny, it's that same thing. But what it does is it starts to break down the skin. So that wound can get bigger just because of too much moisture. And if they're not changing the dressings often enough, that exudate, that the wound is making can make these skin edges wet and make them unstable. And then that wound's going to get bigger, even though you've got all the slough and everything off of it. And for the most part, it's granulating. They're making it bigger because they're not changing it often enough. So that's someone's like, hey, you're doing it every 2 days. Let's try to do it every week and every day until I come back next week. If they're doing it once a day, maybe they could do it twice a day until you come back the next week and see if that helps. Firmly adherent tissue. This is like an example we had before. You can see that's like an eschar that's just glued on there. So this is something that you're going to have to take off with a scalpel. And like that one photograph, you don't really know what's going to be beneath these. But I can tell you that with an eschar that big, it's not just going to probably fall off on its own. So that is something that sooner or later you're going to have to debride. And then once you got that dead tissue off, you've got a wound covered here mostly with slough. You'll be able to slowly debride this slough away, have a nice granulating wound, and then it can start to heal. That'd actually be a good wound right here. Once it is granulating, to put a skin graft on. Epithelial tissue. So this is as wounds heal and get into that nice proliferative phase of healing, you'll see this at the edge. And this is different from maceration, right? You can see these little areas and then this kind of area right in there. And basically it's the skin, that epithelial tissue just kind of growing over the granulation tissue. You can kind of mistake it for slough sometimes. That white stuff here looks like it could be slough. Really, it's just epithelial tissue starting to grow over. So you don't want to start taking off epithelial tissue. You're really just pushing the wound back, right? So try to make that distinction. Usually it's pretty easy. You just kind of see it at the edges, and then eventually you can kind of see little islands of epithelial tissue start to form. Try to avoid that nice healthy tissue and just get the slough. Like I was saying, we're going to do tissue estimates, 10% increments. Looking at different exudate. So this will be important when it comes to what kind of dressing supplies we're going to use for the patients. It's basically the liquid that's produced in response to all the tissue damage. So typically the deeper the wound, the bigger, the more dead space, the more exudate it's going to form. Also, if there's infection present or high biofilm or bioburden, that's going to increase exudate. Certain wounds like venous stasis have a higher level of exudate just as is, but we want to kind of quantify how much exudate there is and then what kind of exudate it is. So different kinds is serous, which is just kind of like a clear yellow, looks like almost like apple juice. Serosanguinous is yellow, you know, like urine, but it's got some blood tinge to it. That's kind of one of the more common ones. Sanguinous is just bloody drainage. Seropurulent, so it's not pus, but it's turbid fluid, like turbid yellow fluid. And then you've just got frank pus, right? So those are the kind of different types of exudate. And then when you're looking at amounts, we usually will do minimum, moderate to severe. And a good way to estimate this is to look at the dressing that's taken off of the patient. If that dressing is approximately 25% saturated, that's going to be minimal. If it's 25 to 70%, 75% saturated, that's going to be moderate. And then greater than 75 would be severe in terms of amounts of exudate. Excuse me. A lot of the times the nurses may have taken the dressing off before. So you can ask them how much is coming out of this wound, because if the wound's all clean and dry by the time you see it, you really can't get a good estimate. So it's really kind of critical to know what the dressing looked like before. And that's just a large copious amounts. Wound odors, like I said, definitely a key. I definitely have gone in the patient's room and like, dude, this wound is infected for sure. But really the patient was actually just sitting in a bowel movement. Everybody's bowel movement smells different. Sometimes it smells like dead tissue and you can get confused. Certain kinds of infection will definitely give a different kind of odor. Pseudomonas being one of the most notable ones. You get this kind of like green exudate and sort of a fruity smelling odor. But always try to pay attention. That's going to give you a good heads up if this wound's infected or on its way to getting infected. And also really important when you're examining eschars for stability. Because if an eschar smells, is it just that the feet smell and there's like a really perfect eschar, or is it not a foot smell and it really smells more like dead tissue? Because if it smells more like dead tissue, then that eschar may be unstable and may need to come off. Looking at wound edges, you want to see if it's epithelializing, see if the edges are curled or rolled. If they are, that just means that the wound is more chronic and it's going to take longer to heal. Curled or rolled, or that epibole, you have to kind of debride away those edges. Is there scar around it, meaning it's had a significant amount of healing in the past? And you'll see this, like sometimes you'll see pressure injuries that are maybe this big, but there's like that much scar around it. So just things to note on your exam. Ideal wound edge is something like this, where you've got nice, healthy scar here on the outside. And you've got epithelial tissue right here at that wound edge, like that. and then all this nice healthy granulation tissue in the middle. And you can see these are those epithelial islands that I'm talking about. See that? That kind of off-white. That's not slough. Don't debride that. That's good healthy tissue. But that edge is nice and flat. It's clean. It's not rolled. It's not hurled up or anything like that. It's intact. It's not, there's no undermining, no tunneling, nothing like that. So that's like a really good wound edge. Epiphyllae are like these curled wound edges, or like it's growing. See how this is literally almost growing down into the wound? Right here, that epiphyllae, you need to treat this. Otherwise, that area is not going to heal. You can treat it with silver nitrate. I usually will take a curette and scrape right along there, because what will happen is that the edges grow right into the granulation tissue and the epithelial will not cover. So when you get right down to this location, you just debride away that kind of callus and dead tissue right here, and that'll allow that epithelial tissue to start to make its way across, just as it has down here. You can see how skin is literally starting to come across the heel right there. And you can see also this little white edge, and that's epithelial tissue trying to do that. So if the wound's not getting better and you've got this kind of rolled edges, you need to kind of like trim back those rolled edges a little bit. Induration or hardened tissue, these are classic diabetic wounds here. No callus, but you can see how indurated it would be. This is somebody, you might want to think like, you know what, you can look at the rest of the foot, probably guess there's a fungal component here. Use some topical antifungals. Classic diabetic callus right here. And a lot of the times I see providers look at this and they'll go and they'll debride away down here in the wound where that granulation and some slough is, but they leave the callus. So you don't want to cut everything away and make a giant wound. Don't get me wrong. But you want to kind of take that curette and score and remove some of that excess callus so you've got nice, healthy tissue. Those wound edges need to be a little bit healthier than that. This is the classic irregular appearance of like a venous stasis one. Nothing really you need to do about that wound edge. I would just debride away this tissue. And then this is sort of like, if you were to describe this, like very non-adherent wound edge, unstable tissue, necrotic slough in the middle of the wound that you can debride. But this is just like basically just a mess of an edge right there. So you got to get rid of this junk. And then you can kind of use gauze and whatnot. Get rid of a little bit of this excess tissue here, some of that dead tissue. It almost looks like like old dead blister tissue that gets stuck down. So it's just a way of trying to get the whole area clean. In a way, when you're doing these wound cares, is you're taking a wound that's like a chronic wound that's not healing, and by debriding it, you're getting away all the bad stuff, and you're trying to restart it growing in the right direction. So you remove all these inhibitors of healing, and you're trying to get it to go back to like an active wound so it can heal properly. These chronic wounds will kind of sit in that kind of thing like this, and that's not going to heal unless you take some action. It just won't. Same with these. You need to cut away some of that dead scar tissue. You got to get down deep in here, get all that biofilm and all that junk out of there, so that chronic wound is now turned back into like an acute wound, and then it can start healing properly. That's one of the main goals of debridement. Peri-wound skin is 4 centimeters outside of the wound, as it shows here. So is it macerated? Is it bruised? And that can kind of tell you what's been happening. You can see all this bruising here, all this new pressure. You've got some maceration here where some of the skin's been peeled off. This is just classic maceration here, like totally pruned up, just sitting and like are they sitting this heel in like a bath? I honestly don't know how it can get that macerated. But if you've got, really, like if this wound right here is draining a lot because there's maybe underlying osteo in the heel, and they're sitting in a dressing filled with pus all day, I can imagine that turning into like this.
Wet dressings after showers.
Yeah, that would make sense too. So if you are seeing that maceration, like I said before, when we get into the next thing, there's definitely more dressings that can be used that are better for higher exudate levels. But at the same time, they may just need to increase the frequency of dressing changes, right? If that's once a day, it may have to be twice until like you don't want to be totally like this. In terms of this one, peri-wound skin, that's just more like, hey, this patient is not being offloaded properly. Make sure they're in a low air loss mattress. Like Bianca said, make sure you check the levels. I can't tell you how many times I see like an 85-pound-year-old woman sitting in a low air loss mattress, and they've got the setting at like 200 pounds, and they're like literally sleeping on a table. So you gotta keep an eye out for everything. And I can tell you, it's like, quote unquote, it's not your job to manage the bed, but it is your job to manage the patient. So anything like that you can pick up on, and this happens at nursing homes, at patient homes all the time. And a lot of the times, if it's a patient homes, it's not their fault. No one's explained it to them. Low air loss mattresses have two settings. I think maybe Bianca got into it, but there's static. And static is for when you're doing a procedure on the patient and there's no air blowing. And then there's the other setting where I can't remember the name of it. It's more fluid, so they're constantly blowing air and stuff like that. But the settings on there are key. You don't want to have a patient sitting on a static low air loss mattress that's set at 200 pounds when they weigh 100 pounds. And then, like how Bianca said, they've got 2 or 3 sheets on there. They may as well be sitting on like an old couch. That low air loss mattress is doing nothing. Wound pain, I kind of mentioned this before, but look at all these things that can cause wound pain. And just think about this: decreased blood perfusion, ischemia, wounds, edema, dryness during or after procedures, and then infection, which I think we're getting into the next slide. But if somebody's got chronic wound pain, that's one thing. You can expect that. But if wound pain changes and someone's like, yeah, it's hurting so much more now, doc, there's something else going on. There's either more blood supply, a blood supply issue going on, there's more pressure damage going on, or there's some sort of infection going on that may not have kind of reared its head yet. But anytime someone's got new pain, that's like a red flag, and you got to figure out what's going on. That is your job. As far as wound infection goes, pretty obvious down here that this looks terrible. Okay. You're going to need to remove all of this tissue. That's an unstable, basically infected eschar. You can see all the air. It's like classic. Soft, boggy, looks like slime. I guarantee you it smells terrible. And you've got erythema, maceration, etc. So it's just like classic. I tell this story just so that everyone's aware, but we had a provider once who saw something not dissimilar to this and debrided it and took a wound culture and said, yeah, it's a diabetic foot wound infection. And then didn't start the patient on antibiotics. They took the culture and then were waiting on the culture to start antibiotics. Then when they went back there the next week, the patient had gone to the hospital and got an amputation. So I'm not saying the antibiotics would have completely prevented it, but if you see something like this that's clearly infected, that patient needs antibiotics like yesterday or maybe even a week before, right? So start them on some sort of broad spectrum antibiotic. If you don't know which one, ask your supervising provider, ask me. Happy to answer. Check their allergies and start them on the antibiotic. Then when that culture comes back in a couple of days, ideally we have something that's coming down the pipe where it should be within 24 hours, but traditionally it's taking somewhere between 3 and 5 days. Then you can tailor those antibiotics to that infectious agent and use specific antibiotics, but do not wait if it looks like that. Same thing with even this. Like this is somebody I would start on IV antibiotics. This is something where oral antibiotics is fine. You can see that little bit of erythema around the edge. You can see the edges of that eschar coming off. So this eschar would need to be removed. And then I would start some oral antibiotics. And I would inform the family or nurse, like, hey, if this gets worse, like, please let me know so that we can either change antibiotics or the patient may need to go to the hospital. But other kind of things to look at, right? Size of the depth of the wound's getting bigger and you can't figure out another reason for it, think infection. More exudate, odor, pain, tenderness, think infection. Erythema, edema, a lot of the times with those, you're going to think infection anyway. But it's just one of those things where if something's not making sense and the wound's getting bigger and you can't really put a reason onto it, there may be something else going on. Biofilm, we'll get into this, but it's classic. They've shown studies where like surgeons have actually looked at wounds and cleaned wounds and said no biofilm there. It looks great. And then like I think almost 50% of the time. So biofilm you don't always see, you may not always smell. It's just one of those things where if a wound isn't getting better, nutrition's good, you're offloading them well, blood supply is good, diabetes under control, still not getting better. I change different therapies, don't know what's going on. Always think about some sort of infection going on. So, and biofilms are super crazy that way. Also, just so you know, we'll get into it with biofilms, but biofilms are somewhat antibiotic resistant, whether it's oral or IV or topical. The bacteria literally are encased in this like extra polysaccharide matrix, and they will sit there and they'll keep living despite what you do. You have to actually destroy that biofilm for it to actually get better. We'll get in the next topic, but these are sort of like the stages. Every wound that you encounter is going to be contaminated. This is not a surgical suite where you're creating a wound. So there's always going to be bacteria there. It's just that when it's contaminated, it just means there's bacteria on there. They're not affecting the wound healing. They're not, they're not like overgoing their boundaries and taking supply from the patient. And typically wounds can heal just fine with contamination. And the next stage is colonization. So again, they're not really causing damage to the wound, but they will start to slow down wound healing. And it may progress to an actual infection. Before infection is something called critical colonization. I think there's a new term for it now, but basically it's where colonization is getting so much that it is affecting the wound healing. The bacteria are taking too much oxygen, too much sugar, too much amino acids, etc., from your body. So the wound will actually get stalled. And then eventually you get local infection that you actually have to treat with antibiotics. All those same things that we said: decreased healing, increased size, erythema, bleeding granulation tissue. So you got nice, healthy, perfect granulation tissue. Not always the case. If you like touch it with your curette and it's bleeding like crazy, think about infection. And then obviously purulence, odor, and new or increased pain. So, but one of the things I just really want to draw your attention to is that hypergranulation tissue, really excessively bleeding granulation tissue may look fine, but there may be an infection going on there. And then there's spreading infection and eventually systemic infection. So once the infection's actually started to spread up somebody's leg or from the back, from a sacral wound up the back, that's where IV antibiotics are needed. And to be completely honest, if somebody's getting a spreading infection, I'm going to send that patient to the hospital to prevent a systemic infection happening at their home or in a nursing home. Nursing homes and the homes are not equipped to take care of a patient once they start to have fever, tachycardia, starting to get septic, right? So if something is already spreading up a leg, if they're in hospice, that's one thing, right? But if they're not in hospice, that's a usual transfer to the hospital. And then, like I was saying, biofilm, you have to always think about this when wounds aren't healing. I literally can't. It's like the same way I feel about doing a good pulse exam is always think about biofilm. And that's the thing. If a wound just isn't getting better and everything looks perfect, just take your curette and scrape off all the crap that's on top. I guarantee you're going to decrease the bioburden. And then the real good treatment of biofilm, honestly, is to do that debridement to get rid of the bioburden and then cleanse it with some sort of antimicrobial cleanser, which we'll get into in the next stuff. But you need to kind of do both of those things. Get rid of, physically break up the biofilm so that the bacteria that are basically being protected are now no longer protected or off the wound. Then treat it with some sort of antimicrobial. And it doesn't mean that you have to give antibiotics, but just some sort of antimicrobial solution to decrease the bioburden, and then keep doing that each dressing change. And then when you're debriding it each week, eventually that biofilm will go away and then it can actually heal. The diagnostics that you guys will commonly order or hear and get a CBC. Reason being, if you're looking for infection or something, a white count is helpful. Hemoglobin is good to know. If patient's anemic, that's going to affect wound healing. Chemistry, just to check their renal function. Albumin, pre-albumin, to check nutritional status. The most important thing with nutrition is not either of those labs by any stretch. Those can be decreased for any number of reasons. And it doesn't mean that the patient is actually malnourished. Really, the most important thing with a malnourished patient is if they're having weight loss. So if the patient is losing weight unintentionally, or they've lost like say 20 pounds, or you can tell if they're cachectic. That's a better indicator of malnutrition than prealbumin or albumin, but these are good indicators, and they're numbers that you can put in the chart. But the most important thing with malnutrition is history and physical, 100%. And then ESR, CRP, I usually am going to order those in patients where I'm worried about osteo. They can be elevated for any number of reasons, but if they're totally normal, I'm not saying it completely excludes osteo, but if they are normal, I don't worry as much about osteo. The thing with osteo treatment is that you're talking about ideally 6 weeks of IV antibiotics. So if you're going to be treating somebody with 6 weeks of antibiotics, you kind of want some good reasoning. You want an X-ray showing osteo, or an MRI showing osteo, an elevated ESR and CRP. White count's typically normal, right? So those labs plus X-ray or MRI, or if you've got just exposed bone that you can see in the ESR and CRP are high, that would be also a good reason. Anytime that I'm going to put patient on 6 weeks of antibiotics, I talk with the primary care physician and make sure they're okay with it, and I usually let them order it. If it is something where bone's exposed, and you can get a good culture, they'll probably want you to do that so that you can really use targeted antibiotics as opposed to, I guess, I don't know. It's not prophylactic because you're treating, but you're treating, you're using broad spectrum against an unknown pathogen versus having something that's targeted. We get duplex ultrasounds and arterial Dopplers all the time. The one thing I didn't put on here was the hemoglobin A1C. That's good to order for your diabetic patients. To actually go and get the trends of their sugars over the last 2 weeks is actually better, but hemoglobin A1C is also good for documentation, especially if you're going to start putting graphs on patients, or you're going to be documenting that diabetes is the main cause for the wound not healing. So this is what a shorthand note looks like. So if you guys were asleep before, I apologize, but pay attention now because this is important. So each patient will have one of these forms, and you basically fill this out at the facility or the home, and this will be basically your skeletonized sort of like notes for how you're going to do your final note. So usually the facility name is up here at the top. You put your name there, patient name here, date. You can put the location of the wound on the patient should you want. It's up to you. I usually do not, to be totally honest with you. And then this will be where you do the wound. Right or left or region. So let's say it's right lateral malleolus, for example. And then you can look at all the different etiologies that are right here. My eyes are failing me. This is pretty small, but there's the pressure stuff here. There's arterial, venous, diabetic. There is ulcer of skin. So when you're not sure what a wound is, there's no diabetes, the blood supply is good, it doesn't look like pressure, it's not venous, it's like on an arm or something. That can be an ulcer of skin because you're not really sure what it is, but you should try to figure out what it is. If it's just like from trauma, there's a traumatic wound, I believe, on there. There's surgical wounds, there's infected wounds, and malignant wounds. And so if there is something that looks malignant, I usually will put ulcer of skin until I get a biopsy proving that it is malignant. But that's just something to think about. All the etiologies and stuff are here. And then you've got basically a pre-debridement measuring and then a post-debridement measuring there. So if it is something that you debride, I usually go up a little bit. So if length, let's just say length was 5 by 2 by 0.2. After I debride it, showing that you did some debridement, it would be like 5.1 by 2.1 by, I don't know what the depth I said. I think it said 0.2. So then it would be 0.3. So you can just go up by 0.1. Usually for arterial ulcers, I do not want to document that I'm making them bigger. So I would do 5 by 2 by 0.2, and then it would be 5 by 2 by 0.3. It has to go up, at least one of those has to go up by 0.1. So typically you're going a little bit deeper, removing some slough, so I usually use it for the depth. There's an area for tunneling or undermining here. So you could say undermining 2 centimeters at 6 o'clock, or 2 centimeters at 6 to 9 o'clock, something like that. And then you have the tissue quality, which is right there. So it's like slough, granulation, necrotic, and epithelial. So 10% slough, 20% necrotic, 70% granulation, for example. And then under that is exudate and erythema, maceration, and odor. So exudate, mild, moderate, severe. And then same thing for maceration and erythema. And then odor, there's like, I think there's no odor, foul odor, and then other. And so sometimes if it's just a mild odor, I'll cross-hatch that and put mild. And then your post-debridement sizes will be up there. And then you want to signify which tissues. And when you're in the field, you guys will see this. You'll see the field assistants or the providers filling this out. So you'll get a lot of experience, but I just wanted to give you a heads up before you're out there. So what area did you debride? Were you debriding subcutaneous tissue, muscle, bone? I can't see what else is in there. But then they have a section up here of all their kind of helpful devices. Low air loss mattress, G-tube, Foley catheter, stuff like that. And then there's others. So if they've got like waffle boots to protect their heels, or they have heel protectors, all that stuff's up there. And so right here, the sort of level of the wound, it's kind of like breakdown of skin only, necrosis or like subcutaneous tissue, muscle without evidence of necrosis, bone without evidence of necrosis. And that just kind of gives you, or you guys, the sort of depth of that wound. Like, is muscle involved, is bone involved, etc. And then over here is going to be your treatment section. So cleanse with like normal saline, Dakins, wound spray, and then you can kind of just put what you want on here. So let's say it's calcium alginate, cover with border foam dressing, change daily. And you can kind of get all of that stuff in this note right here. So, and then this is the HPI section. So if I have any notes like Doppler came back, significant stenosis, venous duplex was fine. I sometimes will put a description of the wound, like wound overall looks infected, took a culture, going to start doxycycline 100 milligrams POBID. So I kind of put any kind of notes on here. And if you need to, you can actually flip it on the back and write on the back. But each one of these big boxes here is for one wound. So if that patient's got, let's say, 5 wounds, you've got all of these sections to do the exact same thing for each wound. And so again, just to repeat, you've got your location, you've got your etiology, continue to there, your wound depth, sizes, tunneling, undermining, pre-debridement, post-debridement, exudate level, erythema, maceration, odor level, depth of tissue debrided, and then your treatment plan. HPI, fill this part out. This is always good. If you're writing something here, you're going to write something in your notes. If you can keep it in your mind, that's great. I usually put notes on here so I remember. And I literally have to go back because my mind gets lost and I can't remember the details of each patient. So those are the shorthand notes for each patient. And that's it for this section. We have one more section on treatment and stuff like that. Do you guys want to take a break? Are you good? All good? Great. Let me see here. All right. Let me see if I can get this to pull up here real quick. Oh, shite. Hang on real quick. I just closed out the one thing that I wanted to show you guys. All right. All right. Let's see if I can present this other section here.
I like your fire in the background.
No, yeah, it's my cabin. It's my cabin. Yeah, it's my
Your
Montana
Montana,
cabin. It's
yes.
nice. It's really nice. It's snowing. It's gonna be great skiing. All right. Did wound management come up there? Can you see
It
it?
is.
It's like a tree. Okay. Okay. Excellent. All right. Last one, everyone. I know it's a long day. But first, we're going to kind of go over tissue management. Basically, your different options in terms of different kinds of debridement and indications and whatnot. And then I'll go over just those basic wound care products, and then we're going to be done. Okay. So basically, wound cleansing, this is before you're doing any debridement or anything like that. You just want to make sure you get a good visualization of the wound, get rid of some of the either slough or exudate or whatnot that's kind of on top of the wound so you can actually get a good look at it. If it is something that you're going to be doing any kind of wound culture or something like that, you want to get all that junk off. I actually usually will almost debride first before I will get the biopsy for culture. And it's just a good way of getting your whole wound clean. And this is what the nurses are going to be doing in between your visits. So you can kind of teach them. You can get kind of aggressive with a little bit of gauze and some cleansing solution, whether that's saline or some form of antimicrobial spray. It's a good way for them to kind of do that in between your visits. You don't want to be the only one getting rid of this stuff once a week, if that makes sense. And basically the whole purpose of debridement is to get dead tissue, slough, bioburden, necrotic tissue, to get that all out of the wound. And like I said, take that chronic wound and push it back to an acute kind of wound so it can start actually healing again. So you're really just taking away one of the main inhibitors. So there's the inhibitors like blood supply, high blood sugar, malnourishment, pressure. That's one part. This is really the other part of the job, is now physically taking away the barriers that are preventing your wound from healing. And it's typically dead tissue, which carries with it bioburden and infection and all that kind of stuff. So the goal is to get rid of that, put a chronic wound back into an acute wound type setting, and let it start to reheal from the beginning. And then once you do have an adequate debridement and it's nice and granulated, a lot of the times you're just doing some minimalistic cleaning. So for those first 2 sessions are really key to kind of really get good debridement. And sometimes, like we were talking about, there's loosely adherent slough, right? And then there's that really dense stuff. So sometimes you can't get everything gone in one time. Sometimes you can. It really depends on the patient. And so sometimes it takes several weeks to get all this stuff gone. But each week you kind of keep going back and getting rid of these barriers to that wound healing. When to debride and when not to debride. So you kind of have to look at multiple things that we have talked about, right? Blood supply, that's going to depend how aggressive you can be. And patients that are malnourished or patients that are on hospice. So if someone's on hospice, you're not going to be as aggressive. And then other patients will just flat out refuse certain things. And that's okay. That's their prerogative. Typically, if patients are in the home setting and they're refusing any kind of treatment, we typically don't continue seeing them. You just have to document as such. And I would let your supervising provider know. I usually give it at least 2 or 3 attempts to see if they'll go for it. And then if they just really are refusing everything, or if they tell you from the get-go, like you're not touching me with any kind of scalpel or curette or anything like that, then, we're not really needed. In facilities, however, we do have to see every patient with a wound. So those patients you will see, and you just have to document each week that they're refusing treatment. So, also times to debride when you're suspecting a biofilm, right? Like I said before, if the wound's not healing and everything seems to be in check, always suspect that there may be a biofilm that's there, and that is why the wound's not getting better. Unstable eschars, edges peeling, bad odor, drainage, soft boggy. Doesn't matter where and when, that needs to come out. If the patient has no blood supply and bad pulses, also get them referred to vascular. Just like here, when you not to debride is a stable dry eschar without signs of infection, right? No need to breed those, but keep in mind that picture that we saw with that pretty stable looking eschar with all that gunk that's under it. A lot of the times you'll have a heel thing like this, and I ain't lying. Like you let 2 weeks go by just covering this up with betadine, and it'll peel off like a scab, and they've just got like baby tissue under there, and it's just awesome because you know that it's done. But you will also see the opposite, where you know that it's not just this little scab; it's deeper, and eventually that needs to come off. So if they've got good blood supply, you know it's deep, and you know eventually it needs to come off, then you can do some of these techniques that we'll get into later to try to get that off as comfortably as possible for the patient. But basically, if you do have ischemic wounds and lack that blood supply, that is a contraindication, especially if that ABI is less than 0.4. It is just, it's not going to heal no matter what you do. And so that almost becomes a palliative type procedure. If vascular can't do anything and they've seen a vascular surgeon and they can't help, then your debridement now really does become more palliative. You're preventing infection, you're keeping it comfortable, you're decreasing odor, but you know it's probably not going to heal. Have those conversations with the patient, family, primary care provider, so that everybody knows exactly where you're at. The more transparent you are about that stuff, the easier it is for everybody to kind of understand, versus like, these people don't know what they're doing. This wound's been there for like 6 months and it hasn't changed at all. And it's because you haven't said one word to anybody, right? Save yourself the headache and just make a few of those phone calls in between patients and stuff like that. If you have areas with exposed tendons, nerves, vital organs, large blood vessels, obviously you want to stay away from all that kind of stuff. A lot of the times, you don't have to be super shy in terms of debridement, in terms of worrying about major blood vessels and stuff. If somebody happens to have a wound right over their femoral vessels, right, that's different. Be careful. But a lot of the times these wounds destroy subcutaneous tissue, muscle, and even in the bone. But if they start to erode into vessels, it's going to start to bleed on its own. But always be wary where you are, right? If you're around big vessels, down at the feet, really deep areas, you can definitely go a little too deep, and you usually would know. Just don't go crazy deep on areas where blood vessels and stuff may be. If you get in super deep on a foot and you start having bright red blood gushing out of there, you know, what are you going to do? Honestly. So you got to be a little careful in certain areas. If that does happen, by the way, pressure is always key. One finger is always the best. Jam it in there. Wait till, call 911, get that patient to the hospital. Someone will probably have to drive to the hospital with that finger in the wound, and then somebody can handle it. I carry stitches and stuff with me. I've rarely had to use them. But there are situations where it is like, if you're a deep hole in the foot, you're not going to really be able to put a stitch in there in this kind of setting. So be careful that way. And definitely around big vessels like the femoral vessels or something like that. One thing that I always want people to know is that if you have a patient that's got a big open wound on the abdomen from like a hernia surgery or something like that, or a dehisced wound from an exploratory laparoscopy, like a midline wound that's dehisced, and you don't know where the fascia is, and there could be bowel right under there. I've seen it with my own eyes, where a wound care doctor was debriding it away and got right in the bowel, and then that patient ended up, I had to take the patient to the operating room. So in those wounds, be very careful about that dehisced area. Bowel may be right under there, so be very careful there. As far as tendons go, a lot of the times tendons may get destroyed and you may need to remove them. I had a patient in particular, he had a wound about this big on his leg, on the side of his leg, and I got it completely clean. And there was just, one of the lateral muscles of the leg, you could see an area of tendon this big. It was just bulging out, and it was constantly covered with slough. It was dried out. It was basically dead. The options there, the surgeon didn't want to do anything about it. The patient was non-mobile and didn't care. And then one of the nurse practitioners came by and just cut the tendon. And this was like when I first started doing wound care, and I was like, oh, you can do that? And then like he's like, yeah, I talked to the patient and said, hey, listen, you're not walking. Let me get rid of this tendon and this wound will heal. And sure enough, 2 weeks later, the wound healed. But he had the conversation with the family, like, hey, you okay? I mean, his foot won't function completely properly after this. He's not walking anyway. So there's always indications and different indications. And those are the perfect situations where you should ask your supervising provider, ask me. I'll try to help you through that. A lot of our patients are on anticoagulation. Typically with the bleeding, I'm just a little bit more careful. If somebody's on Coumadin, that's a little different, and their INR is 3, because then if you get in the bleeding, you're in trouble. But a lot of these days, patients are on Eliquis or Lovenox or something like that, so they do have or antiplatelet agents, and so you may have some bleeding risk. Just be careful with that. Collagen and both alginate work really well to help stop bleeding, and really any kind of bleeding you get, pressure is an important thing that you can do. If you could hold really a solid 10 to 15 minutes of pressure with collagen and alginate and really pinpoint the areas that are bleeding, I've never had it not stop. I have had to use a stitch a couple of times. If you can't get it to stop, then that is somebody that you probably have to send to the emergency room or call 911 for. So just be wary of patients that are on the antiplatelets and anticoagulation. More not to the breed. So there are specific wounds, and this is where we get into atypical wounds. We went over like the common etiologies, right? Arterial, venous, diabetic, pressure. But there's a whole host of atypical wounds, which we typically don't see, or we typically don't diagnose, to be honest. We think there's something else, and we're actually wrong the whole time. And if a wound isn't healing properly within a 6-month period, and you've ruled out all those things, like I said before, good blood supply, nutrition's good, sugars are good, there's no infection, you really kind of ruled out the biofilm, still not getting better, it's been like 6 months and it looks the same, that wound needs a biopsy. There's all sorts of vasculitis type diseases. It could be all sorts of weird random things. Like if you look at a wound care book, there's literally chapters on this. All sorts of different things it could be. One of them being pyoderma gangrenosum, and that wound you actually don't want to debride. If you debride it, the wounds actually get worse. Something called pathergy, and so you'll like see a wound, and it's like 4x4. You'll debride it. It'll be all nice and clean. You come back next week, and it's like now 6x6. It's covered with all this dead tissue, and it's like, God, did I make this worse? And you did, but it's not your fault because you don't know what it is. So if that happens, biopsy is key. We do have these new biopsy tools that we will demonstrate for you. Makes it very easy to take a biopsy of an open wound. We will also be using these for tissue cultures, but it's a great new way of doing it. So tissue culture should be back and much more accurate within a day. And this is a great way to get pathology if wounds aren't healing. If you're seeing the same wound for 6 months and you're calling it an ulcerative skin, so you've got no etiology and it's not getting better, someone's going to ask you why you didn't do a biopsy, right? So always think that in the back of your head. And then any kind of palliative care. You don't want to be super aggressive. Malignant wound, for example. If somebody's got a small squamous cell cancer, they're on hospice and they don't want, they're not going to go and have it removed and get a skin graft and all that kind of stuff. You actually can treat it with 5-FU. It's like an ointment that you can put on there. It's actually like more like a lotion type of thing. And that will help just keep it in check. But I've had a patient who had huge fungating breast tumor, like coming out of her chest. It was literally like the size of one of those mini basketballs. It was covered in stuff, smelled horrible. And so we would clean it with Dakins. I'd remove sort of that excess slough just to decrease the smell. It does end up, cancer always ends up bleeding a little bit more than average wounds. So keep that in mind. But that's typically you're not wanting to be debriding cancerous wounds. And that again goes back to that biopsy. If you're like debriding a wound for 6 months and it's not gotten better, and then you find out, or a dermatologist finds out that that's been a cancer the whole time, that just looks really bad, right? So we don't want that. And then lastly, you have to learn when you can push a patient and when you need to stop. If somebody's a little uncomfortable during your debridement, the lidocaine spray helps. There's subcutaneous lidocaine that you can inject. But if a patient is just screaming bloody murder, then you it's not effective. And any surgeon will tell you, like, you can take that patient to the operating room and get it done in 5 minutes. You'll clean it better. The patient's pain free, and everything is, hunky dory. So if it's something that the patient can't tolerate, there's nothing worse than hearing patients scream down the hallway, and then you run in and you see a wound care provider like trying to debride something that is not really best debrided at the bedside. So really, really use the patient's, pain monitor there. But that being said, there is a bit that you can push a little bit to try to get the wound clean, and so you have to kind of find out where that kind of gray zone is. But if somebody is really like screaming and uncomfortable, that is not in their best interest, and overall, it's bad for the patient, bad for business. How to choose the different types of debridement, which we'll get into. We'll kind of get into a lot of the things. This is a little bit more geared towards hospice type patients, where maybe sharp debridement isn't the best choice, and maybe they can't tolerate what you're doing. So there are other things that you can do to sort of prepare the wound better. As an example, if you've got sort of like a soft eschar, it's really hurting a patient, but you got to get it off, and they're just dying with it. I'll show you a technique, but there's really kind of like all sorts of different sort of debridement types, as I'm listing here, that we can use. So overall, there's really two broad groups. There's selective debridement, and that's removing just non-viable tissue. And then there's non-selective debridement, which is removing the non-viable tissue, but by means of removing that, we also remove at least microscopic amounts of viable tissue. And so any kind of sharp debridement that we're doing is going to be non-selective, or what you guys will put on your shorthand notes will be excisional debridement. And then we also have on our notes non-selective debridement, which is typically just mechanical. So that's just taking it with gauze and cleansing with gauze. These other possibilities, enzymatic, maggot therapy, and autolytic, those are not on your shorthand notes, but you can put this in your HPI. Like patients on hospice going to soften the wound via autolytic or enzymatic therapy, and then possibly consider sharp debridement once the eschar is softer, or once the tissue is softer and it's not hurting the patient as much, something like that. So for the most part, for our documentation, we're really only doing non-selective mechanical, or we're doing what we call excisional or sharp debridement, if that makes sense. So either way, we are doing different forms of non-selective debridement with excuse me, the addition of these. Conservative sharp, we are not doing selective debridement at this time. What that would mean is, like, if we have it, I think, for maybe stage 2 pressure injury, where you can remove, like, let's say they had a popped serum filled blister, and you're just going to remove that dead blister. Technically, that would be a selective. All you're doing is removing some dead tissue, right? Or if you've got a DTI and you're removing some dead tissue around the edge of a DTI, but the skin is still intact, that would technically also be selective. But for all intents and purposes, we're doing non-selective mechanical debridement, or we're doing excisional sharp debridement. Those would be our documentation codes. So autolytic debridement is really just letting the body do its own work. Our own body has enzymes that will help break down wounds, break down slough, even necrotic material on its own. So you usually have long wear dressings that will stay on there for 2 to 3 days. I'll kind of get into some different dressings that can do this, and they help basically to soften that slough or necrotic tissue. Great for patients that are in hospice. Great when you see a wound, and you will see them where you'll take a curette to it, and it's just not ready to be debrided. It's too hard, it's stuck, pain. You can soften it up with autolytic debridement for a week or two. It'll be nice and soft, and then you can take your curette and just lightly scrape it off. Much easier. You do not want to use this for infected wounds. If there's infected tissue, it has to come off one way or another. If you can't do it and the patient's just going crazy, then that's someone that needs to send to the ER. But for the most part, either those kind of like unstable eschars or just basically kind of dead slough tissue that really needs to get off, that needs to come out. But otherwise, if it's something that's not infected and it just is that kind of hard, very difficult to breed tissue, you can use autolytic debridement for, like I said, a week or two to remove that. And products that would do that are hydrogels, hydrocolloid dressings, even MediHoney can do this, and that really just kind of softens up that tissue so that debridement a lot easier. Best case scenario, if it's covered, this is hard to get in home patients, easier to get in skilled nursing facilities, collagenase, and the only one we have on the market right now is Santyl. So that will actually cause selective debridement, only gets away bad tissue. So this is something like good for those arterial ulcers, something that would be good for something like pyoderma gangrenosum, right? If you had that diagnosis, it does the debriding for you, so you're not going to make it worse. You're not going to kill any good healthy tissue. You're just kind of helping sort of dissolve away the bad tissue. This is the key here, this synergistic debridement approach that I was talking about. So you can use the Santyl to sort of soften up. See this tissue here? This would be kind of, some of this may come off easy, some of it really won't. And to remove this, you'd have to get pretty aggressive sometimes with the curette. And you end up kind of maybe causing a little bit more damage than you'd want to. So if you were to use Santyl on this for a week or two, this will turn into like goo, nice and soft. You could take your curette and get that right off. Painless for the patient, minimal damage to nice healthy tissue, if that kind of makes sense. So Santyl is great though, stimulates fibroblasts, keratinocytes, endothelial cells, really takes the wound, puts it in this proliferative phase so it starts to heal. So a very good product for doing exactly that. This is that sort of score technique. I literally did this last week. It was on a patient who had an arterial ulcer. The edges looked just like this. It's like not quite unstable enough to where I'm going to take it off. He's seeing vascular this week, so vascular can hopefully help him. But what I did do is you take the scalpel and you get through just the eschar, use the tip of the scalpel, cross hatch it. I actually go those two ways that you see, and then like this, and then like this. You basically just create all these little furrows for the Santyl to get through and penetrate the eschar and get down to the actual base of the wound. And then it actually softens it up. And then the next week you're able to take it off with a lot less pain, and also a lot less damage to good native tissue. So that's like a really good little technique to use. I had thought that I created it until I saw these slides and found out somebody else was actually doing it before me, which I didn't like that, but what are you going to do? Contraindications, if they do have any allergy to it, you don't want to use that. You don't want to use iodine, any kind of high concentration of silver, or Dakin solutions. That they can all sort of deactivate the collagenase. So all you're really putting on the wound is just like an ointment, like Vaseline or something. So you deactivate the expensive product by using other stuff. So if I'm going to use, like, let's say the wound has got like a heavy amount of exudate, we're going to want to use something like alginate to absorb all that exudate. You don't want to use silver alginate, just use calcium alginate. Usually this amount of silver and silver alginate's not enough to deactivate the collagenase, but why push your luck? So you could use the Santyl first, apply a light layer on the wound, put the alginate on top, and then cover that with a dressing. So for the most part, avoid using iodine to clean the wound, avoid using Dakins to clean the wound, and avoid using silver when you're using Santyl. Mechanical debridement, this is just basically like it sounds. You're mechanically just cleansing the wound. Typically it's done with gauze. There are other tools that can be used, but for the most part it's just gauze. And it actually is incredible that this for some reason will cause more pain for patients than actual curette. Like I can take a curette on somebody's wound and clean it, and they're looking at me and having a full conversation. Then once I start rubbing it with gauze, they start jumping off the bed. It's incredible. But so do it carefully. But this is something that the nurses will do in between our visits. so they can help decrease bioburden, get some of that slough off the wound. It's typically what I'm going to do before I use a curette. Some of it comes off really easy. It targets the areas that I need to use with a curette or a scalpel. Yeah, moisten gauze, avoid woven gauze. The gauze you have that you guys will have is the proper kind. The woven gauze can just leave particulate matter in the wounds. Right here, it does remove the non-viable tissue, but it also damages healthy tissue. So by definition, that is a non-selective form of debridement. So if it's a patient that you are going to be seeing and you don't feel needs to have a curette or a scalpel used, and you're just using gauze to clean it, that will be documented as a non-selective mechanical debridement, and that will be in your shorthand notes. And then if you use a curette, scalpel, or scissors or something like that, that's going to be excisional debridement. Hydrotherapy. So I see a lot of nurses do this. Sometimes I see it at patients' homes. It's just a great way of cleansing the wound. Usually it's done just like this. We're not using any kind of pressure or anything like that. But usually it's just cleansing the wound like that. You typically want to start in the center and then push out, so you're not pushing bacteria into the deep wound. You're actually trying to push bacteria out. But it's a good way of actually just cleansing it. If you're going to use any cleansing solutions, it's a good way. I'll get into cleansing solutions later, but that's a good way of just doing it. So typically, if it's saline, I'll start wash the wound with saline, debride, and then wash the wound again with saline. If you're going to use any kind of antimicrobial solutions, it's best to use saline first, clean it, do your debridement, and then put on any antimicrobial. Because you're going to get off a lot of the bioburden and bacteria with your debridement, and then that antimicrobial solution should be put on afterwards to get the stuff that you didn't get that you can't see. Wet to dry, kind of really not used anymore. I'm old school. I know a few other surgeons will be watching this. I still do use wet to dry. I definitely use Dakin's wet to dry type thing. It's just been shown in studies that it's not been as effective as these other wound care therapies. And a lot of the times once it actually is completely dry, it really hurts coming out of the wound. So we have better ways of dealing with it. But usually I only use it if I'm using Dakin's alone with gauze. And it's more of like a wet to moist thing, and the Dakin's is really just to help decrease bioburden. It does cause some toxicity to the tissue, but helps with odor and stuff like that. And we'll get into that in a second here. And then this is what we're going to be doing, sharp debridement. So this is going to be under our documenting will be excisional debridement. So we have scissors, curettes, or scalpels, and just like here, holding away that slough and using some scissors to cut it away. It's the quickest way to get rid of all the bad stuff as opposed to something like autolytic or enzymatic. Basically, a form again of non-selective debridement, right? You can do selective if it's something like a stage 2 and it's just a blister, but for the most part, it's a non-selective way to get rid of all that bad tissue, and by definition, you are going to get down into some healthy tissue as well. It's the fastest way to get rid of everything. Right here, potential for damage to viable tissue. That's why sometimes you do want to use autolytic or enzymatic so that you can soften it up so that you don't do more damage than good, right? We're trying to get these wounds to heal up. The key though, right here, returns the wound back to that acute phase. These chronic stuck wounds that can't get better, we're removing these inhibitors to get it back to like a nice, healthy acute wound and have it heal properly that second time around. Conservative sharp is basically what we'll be doing versus surgical sharp, which is done in the operating room. So if a wound is out of your wheelhouse, it's huge, the patient's in pain, there's bleeding, it needs to actually have like a significant amount of tissue cut away, like a necrotizing soft tissue infection. This can be done in an operating room in like 10 to 15 minutes, painlessly. They're going to do a better job. The patient's going to be happier. So there's no like shame in saying this is above my level, and you just refer them to the ER and they'll call the surgeon and they'll take care of that. Prior to be doing any of these, hammering it back into you, make sure you check the blood supply. Like I said, if you're going to be doing these procedures and patients do not have good blood supply, these wounds will not heal. So some of the things you can do here, and you should document, right? Your pulses, cap refill, right? 2 to 3 seconds. If it's longer than 3 seconds, that means you got some blood supply issues. Arterial Dopplers are great if you're in a facility setting. And like I spoke about before, we're trying to get something called QuantaFlow going, which is basically like it does a toe brachial index. And it's just a little, like a pulse ox monitor, and you can get the index within like 5 minutes on any patient. So hopefully we get those soon. Sharp debridement. So yeah, again, difference between stable and unstable eschars, right? Just to repeat, stable eschars are hard, they're intact, no signs of infection, the edges are stable, they're attached, versus something here where you can see the edges coming off, you see some erythema, maybe there's some odor. Those are ones that need to come off. So stable eschars, typically do not remove these, and especially if patients have blood supply issues. If it is something on the sacrococcygeal region, there's probably going to be a significant amount of damage under it. So eventually you are going to probably have to remove them. That's where you can use a cross-hatch method with Santyl, or if they can't get Santyl, you can use Medihoney. If you can't get Medihoney, you can use hydrogel, anything like that to kind of soften that eschar so that you can get it off without damaging any tissue beneath. Oops, sorry. And then, yeah, these ischemic wounds, make sure you get your ABIs. And then just to go over these numbers again, if it's less than 0.9, you do have some disease going on, usually 0.6 to 0.8. Some will say 0.5 to 0.8. You have that borderline ischemia. Less than 0.4 or less than 0.5 is severe ischemia, and those wounds really are not going to heal. So these are people that need to send the vascular. So again, anything below the knee, make sure you're doing a good pulse exam. Either get an ABI, a toe brachial index, or a Doppler before you're doing any debridement. If it is somebody who's got an unstable eschar, like I said before, you need to debride that one. But again, order all of those things or get the ABI done if you can. And then refer to vascular surgery if there is significant disease. All these same contraindications, ischemic limb, stable eschar, right? Malignancy, like I talked about, there are indications where you can do some palliative type debridement, but for the most part, we don't want to be debriding malignant wounds. Dry gangrene, as we discussed before, if the patient is not willing to have an amputation, ideally you want to keep these dry, and a lot of the times they'll auto amputate on their own. And then anytime, of course, you've got vascular structures, organ, I think of bowel, and then any nerve structure, avoid that. Bianca went over the skin grafts, but that is another kind of thing, feather in our cap. So if a wound does look like it's stalled and everything looks great, there's no infection, blood supply is good, the patient's not smoking, diabetes is under control, stasis, you're wrapping it, and the leg is back to like a normal size and not ballooned out with edema. This is something that we can think about doing these skin grafts. And if that does happen, we'll show you the whole video on all the documentation and stuff that has to go into that. These are all the links to it. So there is a lot. And then, so these are just the different products that we typically use. And what we really want to do is keep wounds in sort of a state of perfect amount of moisture. If there's too much moisture, it's going to be macerated and cause the wound to get bigger. If it's too dry, the wound typically won't heal. So we do want to have the appropriate amount of moisture. And the different kind of dressings you choose will basically be indicated for certain amounts of exudate. And we'll kind of get into that. But you can't use certain dressings. I know Bianca went over it before. And you guys, once you're in the field, will get to know this. Certain dressings like alginate and collagen, you need to have at least a moderate amount of exudate. And then for different kind of dressings that are super absorbent and stuff like that, you need to have an excessive amount. But for the most part, we have primary wound dressings. That's going to be the first thing that goes onto the wound. There's a laundry list of different things there. I'm going to go over the most common ones that we use. But that's the first one that's going to be in touch with the wound. Collagen, alginate, foam, Santyl, topical ointments, the skin grafts. Those are all the things that are going to be put on the wound first, and then those are secured with some form of secondary dressing. The secondary dressings typically are like either ABDs and wraps, or if you're doing something on the ankles or something more similar like this, like a border foam type dressing that would be put over the sacrococcygeal area or something like that. Ideally, silicone is a lot better and nicer on the skin than acrylic. The acrylics can cause some of those skin tears like we went over before. So silicone border foam is really the best way to do it. And then we do have specialty absorbent dressings, which are the ones that have a high amount of exudate. So again, just to repeat, minimal, moderate, and heavy. So look at the dressing or ask the nurse. Less than 25% will be minimal. 25 to 75% will be moderate. Heavy is greater than 75%. And that will kind of come into play with which you choose here. So these little like moisture marks will kind of demonstrate where we're at. So hydrogel, these are typically used to add moisture to wounds. So you're going to use that when you have minimal exudate. So if a wound has moderate to severe exudate, you do not want to put hydrogel in there. Really, like I said before, is that you want to keep these wounds in like a real medium area of moisture. If it's too dry, we want to use a dressing that's going to add a little bit of moisture to it. If the wound is too wet, then we want to use a dressing that's going to decrease that amount of moisture. So if a wound is too dry, arterial wounds, or if you want to use that kind of cross-hatching scalpel technique to soften up an eschar, hydrogel works very well for these. Comes in all sorts of different forms. You can have basically, they have it on gauze, they have little tubes of it, they even have it as powders, all sorts of different ways of using it. I don't use it a ton. The only time I'm really using it is on arterial ulcers or when I'm trying to soften up a eschar and we can't get Santyl for that patient. Collagen we use a lot. You need to have moderate amount of exudate for this. And collagen basically helps clean the whole wound, promotes fibroblasts coming to the wound. And one of the main things it does is that our wounds typically have, these chronic wounds have matrix metalloproteinases in them. And these are actually good. Our body creates them on their own and they help break down bad tissue, foreign tissue, dead tissue. But in chronic wounds, matrix metalloproteinases become out of balance and we have way too many of them. And they actually start destroying the healthy tissue as well. And that's one of the things that keeps wounds chronic. So by using collagen, it actually acts as a sacrificial substrate for these MMPs. And the MMPs will then break down the collagen as opposed to breaking down our healthy tissue. And when it breaks down the collagen, it's just providing amino acids for the wounds to heal. So collagen is very good. If the wound is kind of wet, it will help dry it out. The collagen is used all the time, comes in sheets, comes in different kinds of powders. You can have them mixed with silver, which is an antimicrobial. You can have them mixed here with cellulose, which is like alginate, but even better in terms of its absorptive capacity. It also comes mixed with alginate as well. So collagen is one of our staples used for those moderate exudating wounds. You almost can't go wrong with it, to be completely honest with you. These are just a whole host of these silicone foam dressings. They have them in all sorts of different shapes and sizes. Nurses will cut them at the corners to fit around heels, cut them at corners to fit around the malleoli. And basically, you've got silicone, which is very user-friendly to the skin. You can actually put it on the skin, take it back off, put it back on, and it'll actually stick, unlike acrylics. They're a little bit more expensive, but definitely work the best. And a lot of times, around the feet and ankles, traditionally be using ABDs and wraps, but a lot of times the patients prefer these. So we can use them if the nurses got them. They seem to work really well. They're definitely a lot pain-free removing, very easy to remove. And it actually does add some extra padding. So people will put them on, you'll see it at facilities, they'll put them on pressure points as well to prevent any kind of stage 1, stage 2 ulcers. Alginate and hydrofiber. Hydrofiber is the same as cellulose. So these are for more moderate to heavy. So any kind of wound that's got moderate to heavy exudate, these are going to help wick away that excessive exudate so you don't get maceration all around the edges. And unlike collagen, if you put collagen alone into a wound, the next time you go see them, the collagen will, for the most part, dissolve. Sometimes if it's in the sheet form, there may be some remnants left, which means there's not very much exudate. But alginate and hydrofiber or carboxymethylcellulose will actually remain in the wound, so you have to take it out. I've definitely taken off the secondary dressing and looked. I'm like, what is all that slough all over the wound? And actually, it's just old. It's just old alginate or old cellulose. So both of these are really good. We typically are using alginate far more than carboxymethylcellulose. I'm not sure why, but if a wound is kind of like moderate exudate, alginate's perfect for it. It'll help get all that exudate away from the wound and try to keep the wound in that proper state of moisture. If it's too wet, then I would switch to carboxymethylcellulose. It just wicks the fluid a little bit better. And in general, both work very much the same. If the wound is excessively draining and it's too much for cellulose and or too much for alginate, then really they just have to start changing the wound more often until that exudate is dealt with. And if the wound does have a crazy amount of exudate, you really need to start worrying about infection and biofilm. So keep that in mind. If the wound is just going through super absorbent pads, going through hydrofiber or alginate, and they're having to do it 3 times a day, there's probably some underlying infection in there that you may be missing. It's great to use as the first dressing, as a primary dressing, also used a lot of the times as sort of a secondary dressing as well, meaning you can put collagen or Santyl in the wound first, and then they can kind of loosely fill the wound here with some alginate. And that will actually, the Santyl and the collagen will be gone the next time you come, but this alginate will come into like a little moist pad and keep the wound right at that proper amount of moisture. If the alginate is sopping wet and there's exudate all around here, and you're getting maceration and all that kind of stuff, that's when you want to move to hydrofiber or cellulose. And then if that is still not enough, then you want to use some sort of super absorbent dressing. And this is the secondary dressing. So they've got the border foam, silicone border foam, like I talked about. That's usually for moderate exudate. This is if you got moderate to heavy. These just absorb more, just like the way a diaper would. It just pulls that excessive exudate that's coming from the alginate or hydrofiber, pulls it into the dressing, and ideally keeps it off of the skin. So if it's soaking through super absorptive as well as cellulose, then chances are it's either an infection or they're not changing as often as they're saying. A lot of patients for home visits, they will only apply or give them enough dressings for a month, and sometimes they only give them like 10. So they're expected to wear the same dressing for 3 days, whereas in the facilities, they're going to change it every day. So dealing with home patients and getting them supplies can definitely be difficult. It's one of those things you kind of need to, if it is something that's really sort of necessary, just get in touch with us via Slack and get in touch with the home health agency and see if they can get more dressings for that patient, even if it's just for a week or two, because sometimes it just has to get cleaned up and then that exudate will slow down. It's just another slide on the same thing, saying the same deal that I just said. Antimicrobials. So there's a whole host of different things that we can do. And like I was saying before, all these wounds are contaminated, and most of them are riding in the colonization to critical colonization area. So when you're seeing wounds that are like that, maybe there's a little bit of odor, there's no pus, maybe the exudate is turning into like, seropurulent or like turbid type fluid, but it's not grossly infected. And you don't want to start antibiotics yet. That's where debridement first, sort of break up that biofilm and get rid of the bioburden. And then following that with some sort of antimicrobial dressing is really helpful. So silver is one of the more common ones. There's silver collagen, silver alginate, all sorts of different forms. If you do round in facilities, they usually have a couple different ones that they typically will use, but it's a good antimicrobial and anti-inflammatory. And as you can see here, it covers against all of these, resistant type organisms. So a lot of the times these wounds aren't something where an oral antibiotic may not even cover it. but using one of these antimicrobials, they have a lot less chance of getting resistance. Can you get resistance to silver? Yes. But is it likely? No. Antibiotics, can you get resistance to them? Yes. Is it likely? Yes. The more you keep treating a bacteria with the same antibiotic, it's eventually going to get resistant. So that's why we have so many of these resistant bugs. So when a wound is prior to getting infected and it looks like it's kind of getting that biofilm type appearance, that's when it's good to use one of these, because this is not going to cause resistance. It's not like an antibiotic where you're going to set off any alarm bells with antibiotic stewardship. Like, why are you putting this on there? You didn't even get a culture, etc. This is something that you want to do if you are fearing that sort of critical colonization point. Silver being a really good one. Oops, sorry. And just like it says here, large percentage of wounds have this chronic biofilm. So disrupt the biofilm. That's what we do with our debridement. And then you add the silver in afterwards. Fantastic. You'll see it work very well, can promise you. This is also a great product. Hard to get in patient homes. Hydroferric Blue is the most common one that we use here. And it's got these two antimicrobials in it, gentian violet and methylene blue. So this actually has the antimicrobials in the foam. It's like a foam that's very similar to like almost like a wound vac type appearance, but it's blue. And so as the exudate with too much bacteria is in the wound, it gets absorbed up into the foam. These antimicrobials kill the bacteria that are in the foam, not in the wound, but just in the foam, so that the patient's not sitting in like a bath of bacteria-laden exudate. So it works well. I use it a lot with Santal or collagen first, and then I put this on top. So it works very well. The foam sort of properties of it, when you cover it with a some sort of border foam dressing, almost kind of acts like a mini wound vac. So you get that same appearance of like, cobblestone granulation tissue. So this works really well. Again, just like silver, works very good against all sorts of these crazy bacteria that we most commonly see, as well against fungus. So diabetic wounds on the foot, I think it's shown almost 80% of those will have some fungal component. So these are great things to use whenever you're worried about that critical colonization type period. If there's an obvious wound infection, that doesn't mean you can't use these, but you also have to use some sort of oral antibiotic or IV antibiotic in addition. But these are just good ways of preventing bacterial resistance and keeping that biofilm in check. So it requires the debridement, and then you cover it with one of these antimicrobial dressings. Medihoney does the same type of deal. It's got a very low pH, so it's acidic, so it ends up killing a lot. It also dehydrates the bacteria. Just like the others, it's got, well, also has this here real quick, angiogenesis, increases immune response, improved clinical outcomes, and just like the others, a high level of antimicrobial effects here. So all of these work great in combination with our debridements to help decrease that bioburden. So it's almost like you want to use these in almost every wound, to be completely honest. But if a wound is perfectly clean, no need. But it's like that wound that's kind of like teetering. You're not sure if there's like an infection. You think infection may be coming. Nurses, a lot of the times, like ask, and I go like, you know what? That's a great idea. Let's use it. And then you've got sort of antiseptic solutions. So betadine being one of them. You don't use betadine on usually open wounds. It's toxic to the tissue. So I typically am using betadine on stable eschars to kind of keep the bacterial count low. That's where you guys will see them used the most, especially in facilities. So any stable eschar, usually, or like a dry gangrene of a toe, etc. That's usually the best use for iodoform. For iodine. Sodium hypochlorite or Dakin solution also can be toxic to tissue, but is good at killing bacteria. Super effective at decreasing odor. So you typically don't want to use this for any more than 2 weeks at a time, but really helps to kind of deal with odor in wounds and helps clean up wounds that are kind of grungy that you feel like you've done a decent amount of debridement, but there's still like a fair amount of slough on there. I find that sometimes doing wet to moist dressings with Dakins is really good. Sometimes it's more you just debride the wound, you then cleanse with Dakins, and then you can put something like collagen or alginate into the wound to add that antimicrobial effect. In terms of treating wounds with a bad odor, there's really two good options. One of those being Dakins, the other being Flagyl or metronidazole. You can just order a 500 milligram tab, have the nurses crush it or the family crush it. It's actually a lot easier. And it's basically a powder. And you just put it in the wound each dressing change. So if they're changing it every day, they'll need a metronidazole tablet crushed and put in the wound every day. And you'll be surprised the wound will smell terrible. And after you do that for a week, the smell is almost gone. The Flagyl is a great thing. I had never known about that in my previous career, but I find that to be super helpful in terms of odor. So think about that for hospice patients where you don't want to go crazy debriding, but the wound smells terrible. Dakins works great, and then Flagyl. Vosh is hypochlorous acid. So it's actually got a better antimicrobial sort of spectrum than Dakins does. It's a lot less, it's not toxic to tissue. So this is a great one to cleanse the wound with. Again, after debridement, get rid of the biofilm, get rid of any bioburden, and then cleanse the wound with Vosh. You can use Vosh in moist to wet too if you need to, but usually it's just used as a cleansing agent, but it's going to always be the best if you use it after you debride, but a very good antimicrobial after you debride. And then you can put your primary dressing on and then your secondary dressing. For the most part, topical antimicrobials like like any kind of triple antibiotic ointment, Neosporin, etc. I usually am only using these for prophylaxis. It does have the ability for the bacteria to become resistant to it, so it's nothing that you want to be treating chronic wounds with. Like, you don't want to be putting this on wounds that have been there for 3 months and using it for a month. All you're creating is more resistant bacteria. Usually use more for, like, if my son cut his arm and I put some stitches in there, I'll put some Neosporin on there. So that's typically the better way to use it. That being said, gentamicin and Bactroban can be a little bit different. Gentamicin ointment can be really, really useful with diabetic wounds, venous stasis wounds, if you feel like they're getting a high bioburden on there, and can be effective in mupirocin specifically for MRSA. So if you have MRSA ones, you can use that for like a 2-week period. Any of these things, you don't want to be using for more than, say, 2 weeks. That'll put up a flag. Same thing there. And then so for antifungals, this is something that you will experience a lot, especially in nursing homes and patient in their homes as well. Either in the groin, under the breasts, under the pannus, or like kind of more like athlete's foot. I would say, maybe like 20 to 30% of patients we see have those really bad onychomycosis or these fungal infections of the toenails here. So these aren't going to be great. The topical ones aren't great for that kind of fungus. I'll go over that in a second. But it is something where you can treat any kind of athlete's foot, stuff like that. Nystatin powder under the breast, under the pannus. Anytime where you've got candidal type infections, any sort of topical antifungal works great. Diabetic wounds, you can apply this along with something like collagen. Like I was saying, sometimes diabetic wounds up to 80% have fungal components. So always kind of keep that in mind. These are just the most common ones. I'm usually using clotrimazole, but any of those will work. Terbinafine, they got a spray, good for athlete's foot. But these ones are better for the toes, for the onychomycosis. Penlac, I typically use, it's almost like a nail polish. And they just apply it twice a day. It's awesome. If any patient has those big giant nails, if you can get it for them, they will thank you. Then it either heals it or the nails just fall off and then the nails will regrow. Nails on the feet typically will regrow. So if it does fall off, tell them not to freak out. They should grow back. But the Penlac works great. And once I started using it, it was like a godsend because as you guys know, there's like these fungal infections and you've got wounds right there. It's just like, God, it's a nightmare. And you don't want to be having to use oral antifungal if you don't need to. Like putting somebody on fluconazole for a month or something like that. If I do think that a fungal infection is bad enough, again, I'll contact the primary and let them know so they can check LFTs and all that kind of stuff, just in case, because I know some of those can cause liver issues. So Penlac is a great thing that I had found. Going over wound cultures, just real quick, we're planning on doing something new soon, which should be something that you all would be using. We're actually doing a tissue culture. So it's basically like a biopsy. Basically a punch biopsy is kind of what it is. And typically, though, we've been using swabs. And so the swab way of doing it, you get about a 15% accuracy. And a lot of the times people aren't doing it right. So I'll go over the proper technique for a swab if that's all you got until we have the other technique. But the swab is definitely, it's used everywhere. I'm sure you guys have done it or seen it before at least. It's easy, it's convenient, non-invasive, it's cheap, and most labs will do it. It does usually take between 3 and 7 days, depending on whatever lab it is, to get your cultures back. So like I said before, you do need to start some sort of, broad spectrum antibiotic and then tailor it down once those results come back. But with like a 15% accuracy rate, I've seen a lot of PAs ask me like, hey, what would you treat this with? And they send me back culture results and there's like 3 or 4 pan-resistant bugs and the oral antibiotics will not treat. And I've looked at the wound. The wound doesn't look infected at all. And maybe the family pushed for it or the hospice pushed for it. And then they end up getting, 2 weeks or 10 days of 3 IM injections a day. Because a lot of times they don't want to do IV because the patient's on hospice, they don't want to pay for it. And I don't know if you guys got vaccinated, but imagine getting like 3 vaccines a day, for 10 days for a 15% accuracy rate. So Bianca knows I've been pretty hard in pushing towards getting a tissue culture, which is about 85% accurate.
We have a meeting with them tomorrow to sign.
Excellent.
Get everything signed.
Yes. And so when you get a tissue culture, it's 85% accurate. So now I'm like, okay, great. Now we can at least we're treating it properly. And the reason is like when you do the let's see, the tissue swab, I'll kind of show you basically how to do it. It's called the Levine technique, and you don't want to be, and this goes for tissue biopsy cultures as well. You don't want to culture slough. You don't want to culture necrotic material. You want to culture granulated tissue, because where the bacteria are, the slough and all that stuff is just contamination for the most part. But the bacteria that oral antibiotics are going to be targeting are the bacteria that are deep in the wound, typically a couple millimeters under that granulation tissue, that are in that granulation tissue competing with our natural cells for our products, like taking our oxygen and taking our nutrients. That's where those bacteria are. Those are the ones that we want to target. So you have to find an area that's clean. You cleanse the area first. Typically, normal saline is the best way to do that. Find an area where there's granulation tissue. This is the wound. Take the swab, and you really want to put the swab right in there, and you want to push deep in there. You want to try to get the fluid that's actually under those cells to get expressed into your swab. If you're kind of swabbing all over the wound, it's going to be, for the most part, contamination. That doesn't mean those bacteria aren't there, but that's why it's so inaccurate. And what I see somebody do is they take a wound and they just take the swab and they rub it all over, and then they put it in the container. So it's basically a worthless specimen. So to do it right, take the swab, push it in a tissue, try to get fluid from that tissue, and then sterilely put it into the container. The new way that we have is it's literally, it looks like a pen like this, and there's like a little tissue grasper at the end. You just put it into that clean granulation tissue, do a couple of twists like this, you get a tissue biopsy, put that in the specimen container, and then you're done. And that'll be far more accurate. So, so these are the disadvantages of a swab. So not always accurate. Like I said, only about 15%. You're only getting the microbes on the surface. Not reliable if deeper microorganisms are different than those on the surface, which they typically are. And then difficult to identify anaerobic, and it takes longer. The other thing too is that if you're culturing on an area where there's a biofilm, you're probably not getting into that biofilm, where this tissue biopsy or a punch biopsy will actually penetrate the biofilm and actually get those bacteria. So far more accurate. And once we have that, I would say please use it as much as you can, because you want to have accurate numbers. And then basically, when are you going to be treating it is, this is just the punch biopsy tool there, right here. So it'll come back, contaminants will grow, but then once you've got greater than 10 to the fourth or 10 to the fifth colony forming units per gram, that means you've actually got an infection there. And those are the ones that they'll actually take out, and they'll do culture sensitivity type things like that, so that you know which antibiotics that you should actually be using. And then if you do have questions about, because some of them will come back where only IM or IV antibiotics can be used, but that's always like, reach out to your supervising provider, reach out to me, I can help you try to interpret that. But yeah, doing cultures just willy-nilly usually ends up bad for the patient and creating more bacterial resistance. So it's something that you kind of really want to concentrate on doing them on the right patients and for the right indication. And so I think that's it. If you guys have any questions, like, please feel free to ask them. I know there's like a ton of information that comes through in one day. A lot of this will be reiterated to you when you're shadowing. You'll see how the notes work. You'll see the wounds and the etiologies in real time. You'll see how they document it. You'll see debridement. You'll learn how to do the debridement. And we ideally want you shadowing for a couple of weeks. We're kind of extending that. And that's really just to make sure that once you are on your own, you're totally ready. And I think that overall will be a good thing for everybody. So hang in there. The shadowing can be kind of frustrating, but it's actually a great time to learn and kind of hone some techniques with the breeding and just get the whole flow of everything. So if you guys do have any questions or something comes up, please email me or Slack me. I'm almost always available. If I don't get back to you, I will as soon as I can. And I thank everybody for paying attention. I know it's a long day, just tons of information. Like Bianca mentioned before, it is on video, so if there is something that you want to go back and look at, you can. But yeah, feel free to ask any questions you guys need to at any time. And welcome to Omni, by the way. Very happy that you guys are here.
And just to let you know, usually it takes a few hours, so typically like tomorrow afternoon. This recording will populate on the calendar invite. So if you ever want to go back and look at it and don't know where it's at, it'll actually populate on there. Like I said, give it a few hours. Sometimes it takes a while, but it will be available there. Additionally, if you haven't got your shadowing schedule, please message us and we'll make sure that you do. I know the office was evacuated right now because there's a fire near it. So I'm not sure if everything was done. I will be checking. I think I've seen one go out, but I'm not sure. But, you know, please let us know. Did everybody get a delivery of supplies yet or anything? Willie?
I did not.
Okay, I will send a message and make sure that those get sent out in the next couple days. Hopefully they're not evacuated tomorrow, so they can ship it out. And you should be getting a tablet too within that.
I haven't received mine, but Tariq said he was sending me some supplies, so I think mine is on the way.
Yes, I think yours is coming from a different shipping, but I will check with Tariq. I believe tomorrow you're probably meeting with him or somebody else on the team.
Okay.
And then for these supplies, it's not something I would need for the shadowing, right?
Correct.
Okay.
Diana, yeah.
Yeah, it's typically sent out like right before you end your shadowing, but I know your shadowing is going to be for a little bit of an extended period of time, so we have time to get you your stuff
Yeah,
out.
no problems at all.
And then additionally, I'll start a Slack message between you and me and Dr. Rosing, so we can set up that meeting. Since you're shadowing for a little bit of time, I may try to figure out a day where we can actually go with Dr. Ryan as well, or Dr. Din. Can one of the two of them, and we can all go out to lunch together, and then try to get that Part B dressing representative to come out and kind of show all of you guys everything. So kind of kill two birds with one stone as well.
Okay, that sounds nice.
Perfect.
Thank you guys for your time. Really appreciate it, and welcome. And we are here for any questions and any issues. So please let us know. We want to make it try to go as smooth as possible for everybody. And have a good day.
All
All
right.
right.
Thank you. Have a
Thank
good
you.
day.
Bye,
You
guys.
guys.
Good one. Thanks, guys.
Thanks, Billy.